thank you for joining me, Dr. Gunson. It's an honor and a privilege to have you on the JawHacks podcast. The audience has been long awaiting your arrival as a guest here, so thank you.
You're welcome. It's good to be here.
Doctor, you have a reputation for doing especially aesthetic jaw surgeries. When people talk, amongst each other and amongst themselves about who does the most beautiful jaw surgery, your name is often at the top of the list. Why is that? What makes a beautiful jaw surgery? What do you do differently? How do you respond to that reputation of yours?
Wow. Well, thank you to whoever thinks that. That's high praise indeed. Thank you. I think to answer that, that's like a historical answer, I think, as well as a present answer. So we only stand on the shoulders of those, that came before us. And I stand on the very broad and generous shoulders of my partner, Dr. Arnett. So he, I would say he's the instigator of all things aesthetic when it comes to orthodontic surgery. It was in the early 90s that he felt like that the way that faces and jaws were being looked at and analyzed was inappropriate, and he was able to come up with his own cephalometric analysis that was based on the face. He took 100 people that he deemed beautiful and gathered averages of different positions of the face, and it was less based on the bones. Of course, the bones influence, but it wasn't like cranially based driven. It was facially driven, and through the years, he was able to prove that it was a better solution for the face. So when I joined the practice in 2003, I inherited that. And so I would say that's where it starts. From there is the last 21 years of my practice. It's been an effort to figure out where maybe that analysis isn't fully complete. And I feel like the last frontier of aesthetics is understanding facial function and how the face works. So there have been a lot of discoveries along the way about where the parts belong in the face. And when you can put the parts of the face together in a way that allows it to do what it's supposed to do, the face is relaxed. And it's that. So you have a position issue, which, is brought to bear with the Arnett analysis. And then you have this functional issue, which if you can solve, allows the face to relax. And then a relaxed face expresses its full aesthetic. So, for example, a mouth that's relaxed has fuller lips, and that's considered more aesthetic. Mm-hmm. So I would say that's the general explanation of how we strive to get good-looking faces as we want.
So you called it the Arnett analysis. So that, I presume, is different than what's taught to a resident in orthodontic surgery or someone still in training at school. This is like a unique cephalometric program that you and your former partner, and please, in your response, do tell if Dr. Arnett, I'm told he's no longer practicing, but can you confirm that? When did you guys last practice together? And yeah, I'd be interested in some specifics about how the Arnett analysis differs from the textbook that you might get at school as a surgeon.
So I don't, I would say, so the Arnett analysis is just a cephalometric analysis, which is an analysis of the lateral profile X-ray. And cephalometric analyses have existed for a very long time. You have prominent names like the Steiner analysis, Ricketts analysis, Coggs, Sassooni, all these greats in orthodontics, and have developed these different analyses to help figure out what the face is doing. Dr. Arnett published his analysis over the course of 2 publications. He called it Facial Keys, and it gets taught in orthodontic programs and orthodontic surgery programs alike. So it's just one of those, analyses that get studied in school. I think that the difference is up until his analysis, and then also Dr. Larry Andrews, his analysis, that people were not analyzing the face independently. It was always a question of where the bones and the teeth are. And so that makes the difference. And then to answer your question about Bill, Bill retired about, I don't know, maybe 6 years ago from jaw surgery, but he's not retired in the sense that he still lectures. In fact, he just gave a lecture to the University of Washington oral surgeons and orthodontists. So he lectures a lot. He helps design software for the analysis and treatment planning of patients. And so he's a busy guy. He's just not operating anymore.
Mm-hmm. What would be, practically speaking, as the rubber meets the road, how is it different to plan a jaw surgery around the face in and of itself, as opposed to building it around the teeth and, as you keep saying, the bones?
Yeah. So I would say there's 2 aspects to that question. One is we'll talk about maybe the difference between the face and the base bones. But then I think we need to talk a little bit about what the word normal means, and when we talk about normocentric analyses. So the difference is that initially what all these cephalometric analyses had done is they took people who were considered class 1, so that their bites were fitting together, really nicely. And they took, X amount of subjects who were considered to be class 1, and then they measured the position of the parts in their teeth and their bones to get a distribution. They want to find out the highest distribution of the position of any part that they might be measuring, right? So they come up with this bell curve, and what lies in the middle is what they call normal. So, for example, in the Steiner analysis, they would look at where the position of the upper jaw is relative to a point here in the middle of the skull, the nose, and then down here to where the bone is. And so the question for Steiner was, hey, where is this bone point right here relative to this cranial reference point for this group of patients? And, that's a great analysis. It's epidemiologic. It's trying to find out, what the repeating position is for that location. And it served us well for a time. But that doesn't really have any kind of relationship to the face itself, because that's a hard tissue point. And so after that came my orthodontist. The guy that did my braces was Robert Ricketts. And Dr. Ricketts added a lot of facial points, so like soft tissue analysis. He came up with, I guess maybe his most famous would be the E line from the nose to the chin. And so he was interested in the face and how the face looked based on the bones, but his analysis still relied on a lot of structures up here in the cranium, and those are reference points. Another example might be, there's a reference plane that a lot of surgeons use even to this day called Frankfurt horizontal. And it's from, the tragus to the eye. And that was a reference plane that was established for epidemiological purposes, for the purposes of studying populations. There's no inherent meaning to the Frankfurt horizontal line. It's tragus to the eye, so the canthus, and it's like, or to the inferior orbital rim, and it has no inherent meaning by itself, and definitely no relationship to the face. But through the years, Frankfurt horizontal, and even up to today, is used as a reference point to build faces. So it's like, why are we using that? So what ends up happening is Dr. Arnett then decides, well, why are we picking origins of measurements? Like, why are we looking at the face, but then comparing it to sites that are up here in our cranium? And what he did is he started from the point, okay, where's the center of the face? And he deemed the center of the face here underneath the nose at a point called subnasale. And so all of his measurements come from a point and a plane that travels through subnasale. And he measures where the lips are. He measures where the cheeks are, where the chin is, and the soft tissue, nose, chin, lips, as well as the bones. But all of those measurements are made to a plane that exists out here in front of the face instead of up here in the cranium. Mm-hmm. And so that becomes a meaningful reference, right? So that's a meaningful reference point as opposed to the cranium, which are reference points that were chosen for ease of repeatability, right? So if I told you, hey, find Frankfurt horizontal, okay, Horion orbitale. That's easy to find in every cephalometric tracing that you have. But again, it doesn't have any meaning for the face. So what does that mean? That means that, okay, you take one jaw surgeon who is going to use these older cephalometric analyses to find out where to put the face. And they're going to be right a fair percentage of the time based on the studies of what is considered normal. But they're not going to be right all the time, because the patient who's sitting in front of you doesn't necessarily belong to the group of patients that were studied back in the day when those analyses were studied. They might lie, so for normative analyses and statistics, you have a curve. And if you live underneath the curve, you're considered normal, like in the middle. But you could have a patient whose basic facial form is out here on the edges. And if you treat to the middle, you're going to miss that patient, right?
Right.
So what his analysis did, because he's studying 100 beautiful people, not 100 correct, tooth position people, he is building in bias towards, quote, beauty. Of course, it's in his eyes, granted, but it removes a little bit of the bias. So the reason his analysis works better is because, one, he injected the bias of beauty, and two, it's the face that he's analyzing. So, but even with Dr. Arnett, the patient who's in front of you is not necessarily, he or she doesn't really always fit that mold. And so the question is, Steiner tells us where to put the upper incisor in the face. Arnett tells us where to put the upper incisor in the face. But when that patient shows up into your office, where does it really belong for facial function?
Right.
And that would be the addition to the Arnett analysis, where I try to get a more functional face. So I take things into consideration that have to do with speech and chewing and swallow and breathing, and we've analyzed those aspects and where is the best place for the structures of the face for those things to occur.
Yeah, I think you're good.
Okay.
Yeah,
my screen's just blacked out. I'm sorry about that.
Oh yeah, maybe your computer.
I thought, oh crap, everybody disappeared. Okay. No, so that's I would say that's the the difference. So you have normal, and that's a word it's not a good word for treating patients. Nobody needs to be treated to a normal. Normals help us understand growth and development. But for example, I think you've talked to Dr. Evans before, right?
I have a couple of times.
So Mariana says and teaches that the modern face is a smaller face, right? It's a face that, because of whatever reason, is not as projected as it used to be. Well, if that's the case, and then you gather 100 or 200 people and you do a cephalometric analysis and you take a normal of the population, now your normal is a small face, right?
Right.
So then what are you doing? Every patient you're treating shy of their best, whatever's best for that individual. So you have to be careful. Again, I respect all the research that's been done through the years. You have to. It's like I said, you stand on the shoulders of others, but there's more to it. And getting a good result is about making the face work.
Mm-hmm. So you have, let's say, the Steiner analysis, and surgeons that use that. You have the Arnett analysis, and then you have the modified Arnett analysis that considers function and perhaps airway. Maybe not airway. I don't know. You can comment on that. But how much difference are we really talking here? Are we talking a few degrees either way, a few millimeters either way? I mean, there's limits that the material structure in front of you imposes on the surgery too. So when all is said and done, how much are all of these approaches within like 15% of each other? How much difference are we talking? And then how much difference does a 20% difference in how people do things, how much does that affect a really beautiful, like, wow factor face in a before and after versus, that looks unnatural? Is this a game of fractions of a millimeter? What are we talking about here?
I mean, it can be. It just depends what the problem is. And so when I talk about function, it's really separate from the quote Arnett analysis or the cephalometric. When I'm talking about function, for example, I'm talking about being able to get your lips together. So I think we can all agree that the lips need to be together. Science has proven as much, that we're obligate nasal breathers as human beings, and which means that our brains are hardwired to breathe through our noses. And when we don't breathe through our noses, not only is it inappropriate to the physiology, but mentally it's disconcerting and disturbing for people. That's why, so take it from a standpoint of social norms. That's why we have pejorative terms like, hey, mouth breather. There's this underlying like recognition in our souls that people that mouth breathe are not healthy, that something's wrong and they're not part of the pack. And that's a problem, right? So having the lips touch, that's not part of any analysis. That's a functional decision, right? Well, how close do the lips have to be together in order for it to not be dysfunctional? So, I mean, that's really your question. It's like, is it a question of millimeters or fractions of a millimeter? And the answer is, well, it just depends on the size and shape of the lips. So when you have a patient that you're looking at for surgery, let's use, for example, the Steiner analysis to position the parts. But because Steiner doesn't take into consideration the lips being apart, let's just do the surgery with Steiner. Well, that's fine. You're going to get fairly close to an aesthetic result. Maybe not, definitely not as good as the Arnett analysis, which would help you understand occlusal plane and the projections of the face. Okay, great. So let's use the Arnett analysis then on this patient. Well, we're going to get a better result. The balance is going to be better between the nose and the chin because we are now measuring the face. But if we still disregard the lips and we leave them apart, say 2 or 3 millimeters, is that going to make a difference? Well, it depends what you're dealing with the patient. If on the backside of the surgery, you have the parts in the right place, but then the patient has to do this all day to put their lips together, is that aesthetic? No, it doesn't look good.
No.
So your parts might be in the right place according to some analysis, but if they're not functioning well together, then the face doesn't look right, and it is a final outcome. Will the patient? This is a great question too. It's like, which is kind of where I think your podcast comes from. It's like, how do lay people understand jaw surgery? And what's phenomenal is that there are people who can get a big change in their jaw positions, and they are ecstatic with the outcome. They love it. But because they lived most of their lives with their lips apart, and the lips are still apart post-surgery, they don't know. It's like they don't know any different. Nobody told them that it was possible to have the lips touch when they're done. So they're cool with it, right? Because they don't know. But if you actually told the patient after the surgery and said, how your lips don't really come together? Well, yeah, that's, I have to work at it. Well, what would it be like if you didn't have to do that? Oh, that would be great. Oh, okay. Well, let's provide that for you. Let's give you that relief. And then for some patients, the disability of having your lips apart is enormous. Posture problems, neck problems, jaw problems, migraines. And then, of course, the mouth breathing at night, which leads to sleep disorder breathing and things like that. So it can be quite dramatic. So is it a case of millimeters? Yes, in some cases it is. In others, it's more than that, And then, again, as a conclusion, does the patient know the difference? And I would venture to say no. I mean, the individual patient only knows what they're getting. They only know the consultation they're getting. They only know the surgical outcome that they're getting. And in comparison, large discrepancies are going to be visible, right? I mean, those are going to be the obvious ones. But in the end, when you talk about these minor things, then maybe not so much. But is it worth it? Yeah. I mean, it's worth it. It's where I grew up. In residency. I grew up in residency. I learned how to do surgery in residency. And there were some attendings in residency that were like, well, if you're not going to do a 6 millimeter genioplasty, what's the point of doing it? Well, I find there's a point in doing a 2 millimeter genioplasty for sure. If I can get the lips to touch, or I can get a balance out of 2 millimeters or even a millimeter, I'm going to do it. Because why? The surgery itself is so inaccurate and complicated in general. Why should we cut ourselves short of trying to achieve a functional and aesthetic perfection, which we'll never achieve? But why cut corners if the surgery itself is going to make it difficult anyway?
So it's a sort of aim small, miss small mentality. You want to shoot.
Over-engineer.
Right.
Absolutely. I just posted this on my social media because I was blown away. I'm a rocket nerd. I just love space and all things rocket. And for the first time, Jeff Bezos gave a tour of Blue Origin, and he hadn't opened up his plant to anybody. Nobody knows what's going on in there. And so he let this great podcaster, his name's Everyday Astronaut, he let him in. And within the first 12 minutes, they're standing in front of this giant liquid oxygen tank, and the dome of the tank, that which seals the tank, is sitting invisible, and it has this lattice structure, and it's really beautiful looking, tank, right? And the guy, the podcaster, goes, "Wow, it's kind of beautiful." And Jeff Bezos said something. I repeated it like 10, 20 times, and I was laughing the whole time. He said, that's the thing with function. He said, when you engineer to that last 1% of function, things become beautiful. And I was just like, seriously? You said that? Oh my gosh, that's that's beautiful. And I think I would say that that's what I'm talking about.
Are
You could have a millimeter here, a millimeter there, but if you're engineering to that last 1% of function, you're going to reveal the beauty, the underlying beauty of the face and its structure. So,
is what you're touching upon here similar to like the Japanese ethic of striving toward perfection especially in the creation of material objects? Like the Japanese historically have this idea that there is one perfect way of doing certain things, and they will spend, certain craftsmen will spend weeks or months building a single bowl, or they built these beautiful Buddhist monasteries with these gardens that are very intricate and require lots of maintenance, and katana swords that are not only functional but also beautiful. And they'll, a metallurgist will spend all this time making this one blade. Is that kind of what you're talking about, in applying that mentality of quality over quantity to building faces?
Yeah, it's both quantity, quality. Yeah, and I am talking about that, but you have to be very careful too, because what I'm not talking about is some kind of sterile over engineering, where you measure every part and there's a perfection for every part. I don't want to say that, because there are some schools of thought in jaw surgery in the world that honestly they over engineer, but I don't think there's a functional component to it. So I would say, okay, let's take the katana sword, right? Folded and folded and folded and folded over time, and again and again, and then why? Well, to have incredibly hardened steel, and in the end, that incredibly hard steel holds, a sharp edge better than anything else. So while it ends up looking incredible, having been folded so many times, and you look at the intricacies of it, and then you sharpen it, and for some reason, our eyeballs as human beings look at it and go, "Dang, that is a far different thing than my butter knife, at home." But there's function to it, right? So it's sharp and it's going to cut you in half. So it does what it does. And it looks good doing it. I think that's Bezos's comment, is that when you over engineer for function, you reveal the beauty, and our minds grab onto it. And I think facial harmony and facial beauty, that's what we appreciate as human beings. I lecture on it too. It's like our genetics are programmed to recognize health in other human beings. And the reason is for the propagation of the species. We don't want to share our genetic material with someone who's not well made, because then our offspring are not well made. That's how we protect, genetically the species. And so we're hardwired to think that. And is that true? Yeah, there's science for that. There's some science out there that rates people's attractiveness and then analyzes their immune system and how well they're able to fight off infections and cancers and things like that. And the answer is, yeah, there is a correlation. So our subjective, in some respects, our subjective view of what is beautiful reflects this healthiness. So if you're going to over-engineer to function, and that reveals, again, the beauty of the face. Can I make one caveat, though?
Please.
And that is there are societal cosmetic things, right? There are certain social aesthetics that don't take into consideration function. And these are things that are brought into the society over time that are judged with the frontal lobe, if I can say that, as opposed to the midbrain. The midbrain is responsible for our kind of reaction to life and looking at health and saying, well, that's healthy. But as human beings, we often use our frontal lobes, and we can use our frontal lobes to re-engineer what we think is appropriate. So you have a very, there was a time there where everybody wanted lips that were bigger than their heads, right? They wanted to be plump and
isn't that
and
like
blown
now?
up.
Isn't that time now?
Yeah, I guess I keep hoping that that's not the case anymore. But anyway, so these big lips, right? So society says, "Wow, that's attractive," and our midbrain kind of says that's attractive because big lips means virility. It means health. A big lip is a supported lip, so it means a big airway.
Right.
A big lip allows the lips to touch, so it means the mouth's closed. So we appreciate that as being good. But then what happens is these big lip people, they go to talk, and in order to talk, they have to pull their face apart. They have to lift their lips up, and they get nasolabial folds, and they start talking. And as soon as they start talking, you're like, oh, maybe too much, right? Maybe too much. But that's functional, right? So big lips static looks great. So you take a picture on Instagram, you put that on Instagram, it's like, whoa, look at those lips, they're great. Now you make that person talk and the dysfunction's revealed, and then you're kind of like, no, it's not right. So that, again, I think that's the difference between a positional or a volume problem in the lips versus what their end function is.
Interesting. And to take the big lips example and apply it to a big lip jaw surgery.
Yeah.
We were talking before about lip incompetence. And I think that gets to perhaps over advanced jaw surgeries, and maybe not. Yeah. Please comment. But I think that what would be the equivalent in terms of a jaw surgery outcome that might look good, like on paper, if you're just looking at a two-dimensional side profile where you see these big prognathic, masculine, so to speak, jaws, but then you meet that person in real life and they're like, they're all awkward with their face and they're puckering.
Exactly.
And please speak in terms of concrete jaw surgery outcome examples, because my audience is very technical and they're all interested in, well, not all of them, but a lot of my audience is shopping around their own surgery. And so they're looking for the common pitfalls and what to look out for. And one of the main tensions that I try to get to the heart of is the tension between aesthetic and functional, over advancing, under advancing, finding the sweet spot.
Yeah, that's great. That's a great question. And I think you're right. I think the over advancement, when you recognize that the jaw surgery involves, this structure from the nose to the teeth, and then this structure here, and when you recognize that the face itself is not just attached here, it's attached all through up here, and this is the orbicularis oris. It goes through the buccinator muscle, and then the buccinator muscle dives in and goes to your pharyngeal muscles, which makes for your airway in the back. So, and then that goes around and attaches to the back of your neck. So you have, and I'll give credit to Jeff McClendon, who's a restorative dentist in New York. He calls it the circle of life. So it goes around the back of the throat, pharyngeal muscles, buccinator, out to the mouth. So you have this sling here, like this. You take the jaws and you push forward, you're going to push against the sling eventually. And at some point, the sling's going to push back and retract, right? So it's that sense, if you come too far forward, then the jaws are out in front of your lips. And it's too much relative to the attachments at the back of your neck. And you can't get your lips together. So you're right. I mean, that's just anatomical. So then the question is, well, how far forward then, right? I mean, you want nuts and bolts. It's like, well, where does it go? The dilemma here is, so it like you said, it's aesthetic and it's functional. So if we go back to the aesthetic analyses of the face, and if I could pick three, it would be Arnett, Andrews, and then this soft tissue plane. So Andrews measured the position, and so let's just make it the upper incisor. Is that okay? So we'll talk about the position of the upper incisor in the face, but let's It's the upper jaw, basically. So Andrews measured off the forehead right here. Well, everybody knows that everybody's forehead's different, right? Women's foreheads are sloping back, men's foreheads are bossed, and that can be any of those things. And so that's a variable. Arnett's analysis takes subnasally, but that's a better position. But subnasally moves when you move the upper jaw, so that becomes a variable position during treatment. Finally, you have the soft tissue plane, which surgeon in Spain co-opted and named it the Barcelona plane. But initially it was the soft tissue plane, but he changed his name for his own purposes. But that's Nasion, right? So that's a less variable point. That's great. So where does the tooth belong? Well, you know what? It's funny. You take all three of those approaches and the upper incisor ends up in pretty much the same place. Although Andrews is a little bit further back than the other two. So it's pretty funny. You do the analysis. Everybody's putting the upper tooth in the same spot. Okay, but is that the most healthy spot, right? Well, what is the health component related to the upper jaw position, right? It's airway size. So the idea is the more you go forward, the more tension you put into the ring so that it doesn't collapse on itself, especially in sleep, right? So you hit sleep, you hit REM, you have paradoxical breathing, which means your diaphragm's working and the rest of your body is paralyzed. The tissues in your throat are paralyzed, and then you create a negative pressure and they collapse. So that's snoring. If it vibrates, it's apnea. If it collapses, closed. Advancing the jaws provides tension back there. And if you provide enough tension to prevent the collapse, then you fix the apnea, right? Okay. So we go back to the 90s again, and we go to Stanford, and we have some great researchers, Dr. Powell and Riley, who discover that if you take the jaws and you push them forward, you can fix sleep apnea. And I still remember this. I presented their paper. I was a resident at UCLA, and I was on the ear, nose, and throat service. And at the end of your service time, you have to present a paper, and then you present it to the attendings and the residents, and you present the paper and what it meant. So I presented Powell and Riley's paper that showed a 90% improvement rate in apnea with maxillomandibular advancement. And when I finished presenting it, the attending said, "That's not right." And I said, "Well, what do you mean that's not right?" He said that doesn't happen. And I'm like, well, I'm pretty sure this article just said it did. And then, of course, there's the other article they published a few years before with fewer patients that said that it did. Oh, and then there's Peter Waite's article that says that it does too. And there's Hochbahn's article. What are you talking about?
And then there's common sense.
Yeah, right. Common sense. Well, see, this is the interesting part about common sense, because the common sense then would lead you to say, let's go further forward, right? Well, Powell and Riley, when they did their surgeries, they went straight forward. So they took the jaws and they pushed straight forward, which made for some interesting faces. Because in the United States, one of the main patterns of the airway face is a steep facial angle, right? So the face grows down in the front like this, and we see this all the time in these airway patients. The face grows down. Well, if you're taking a face that grows down and moving it forward, you're not altering the positions of the chin relative to the nose. So what ends up happening is the nose part comes forward too far, which causes this to happen, right? And then the chin doesn't catch up to the lips, which leaves it recessed in the face. Doesn't work. It doesn't look right, and it doesn't work great, but it does address the apnea. So and then along comes
just to for the audience, and so to foreshadow the adjustment that was made or the improvement that was made to that would be upswinging the jaws or counterclockwise rotating them, perhaps. Is that that's the solution?
That's the term. Yeah, that's the term that folks use, is this counterclockwise rotation. So then we discover, okay, in the long growing face, it's best to do this, right? To get the front closer together. Why is that? Well, guess what? It gets the lips together. So it's pretty cool. It also prevents the nose from, getting turned up. Okay. So that is brought to bear in the Arnett analysis, who's keeping track of occlusal plane, right? So he's now saying, well, let's rotate these airway patients and get a better face. And he does. And so people agree to that. And then there's some debate, is it still a good idea to do that in an airway patient? Well, in the end, you have to ask yourself, if you over-engineer a face, if you push it further forward for airway to the point of messing up lip closure or the aesthetic of the face, what do you choose? Well, that's a false choice. Like if you say, for example, oh, I'm going to push further forward and we're going to negatively affect the aesthetics of the face, I'm going to choose function over aesthetic. That's fine. You can do that, right? But that's not your only choice. You have to recognize that airway is far more complex than a hard tissue architecture problem. And if you can't get a good airway by putting the face where it belongs, then maybe you've missed the underlying diagnosis or the concomitant diagnosis, meaning the other diagnosis that's in the face, right? So if you can't make a good face and a functional face by advancing the jaws just enough, but not too much, then maybe there's another underlying problem that you've missed. Because, would nature, that's the question, is like, would nature allow for humans to have really, terrible looking faces to go against the genetics, what we consider to be beautiful? And functionally beautiful.
Could I interrupt for a brief moment? So the way I've made sense of the problem you just posed is that maybe nature did want us in this much more advanced place, but we can't do that now because it looks unnatural to go that far, because maybe the rest of our head is underdeveloped too, or maybe the soft tissue is underdeveloped. It's not voluminous enough to be able to accommodate the bigger advancement without looking stretched, so that the less advanced face is actually not what nature intended, but it's the limit of what nature will allow because of underdevelopment elsewhere over a 30-year period or whatever. Or do you think that just the under-advanced faces that's what nature, some of these over-advanced faces are just unnatural, period?
Yeah. So I'm willing to be open to that thought. Your thought's a good one. Maybe the rest of the skull is underdeveloped as well. That's great. Maybe, but then maybe we ought to be taking a look at, so for example, one of the main disease processes where we find sleep apnea is in patients who have connective tissue disorders. So we have the Ehlers-Danlos patients and the Marfan syndrome patients, and studies have shown that up to 50% or more of people with EDS or Marfan syndrome have sleep apnea. And so now take an EDS patient who has sleep apnea, you look at their face and you're kind of like, yeah, okay, your face is a little deficient. We could do the jaw surgery, but inherently is the problem in the skeletal structure? Yeah, it might be partially in the skeletal structure, but it's definitely in the fascia, right? So the fascia is what holds us together. It's the tension of the system, right? So we have bones and fascia. That's the hard stuff. That's the tension. And then the muscles allow us to move. So the muscles overcome tension. So we're on this spectrum between chaos and rigidity, right? Chaos, if we didn't have the rigidity of our fascia and bones, we'd be a blob. Versus if our fascia and bones are too tight, then we won't be able to move. Now, in the EDS patients, the fascia is poorly made. so it's loose. So that can collapse a lot easier. And then it leads to a lot of other problems, like because the muscles take over. So the muscles take over the system and provide integrity when the fascia is supposed to. And that leads to a whole host of other problems. But here, my point is that then what you're doing then is, if you're going to address this person's airway problem by over advancing the jaw, you're treating the problem where it doesn't live.
Right.
And that's something that my partner always taught. And that is treat the, am I good?
You're a little frozen, but I'm sure it'll come back in just a second. Yeah, you can continue with what Dr. Arnett said.
Okay. And then you can see my pathology. I show my lower incisors when I talk. So, he says, treat the problem where the problem lives. If you start treating problems outside where the problem lives, then you're going to get into trouble.
There it is.
I just refreshed the camera. So that's the issue. That's one of the issues, right? So if you're going to over advance the face, you can choose to do that. It's fine. You just have to know what you're doing. If you're going to over advance the face and create interlabial gap, then you're going to have a mouth breather and you're going to generate somebody who may be relieved of their AHIs, but in the end have RDIs. In other words, they're waking themselves up at night because of the mouth breathing and the use of intercostals, for example, which is, paradoxical to what should be happening. Mm-hmm. So I guess that's my point, is like, there are other things in this world that can cause apnea that are not hard tissue related. The clinician needs to be aware of them and inform the patient of them, because it influences results. You take the. I'm sorry. You can rein me in as much as you want, but if you take the research that's been done for MMA and sleep apnea, right? The research shows that it's about an 88% improvement rate. So 88% of people that have jaw surgery will get a 50% reduction in their AHI scores, which is pretty good. That's almost 90%. That's great for any surgery.
Sure.
However, if you have an AHI of 40 and you get to 20, the surgeon gets to say, that's a success. But the patient still has sleep apnea, right? At 20 episodes an hour. But that is a success rate at 90%. Now you go to the cure rates. The cure rates are 38%.
That's really solid.
Right? That's the best that is available surgically, but it's like a steep drop off from 90%. Why? Why is it a steep drop off? Well, when Dr. Zaghi and Dr. Holte did their systematic reviews of all the studies that have been published, they tried to make sense of the influences that were outside the bony architecture. And what they concluded was, first of all, most of the studies didn't try to find out what the other ancillary diagnoses were, but Holte showed that maybe the jaws weren't advanced enough. That was one aspect, and that's what you're asking, and that's the point that we're making.
Right.
But Zaghi also pointed out that there was a BMI problem. So in a lot of these studies, they were overweight. And that's been proven. You want to fix sleep apnea, lose some weight. That's like the number one solution to sleep apnea. So we know that obese patients have fat deposited around their airway. It makes their airway smaller because it deposits around the airway, right? That has nothing to do with your bones. Lose some weight. So there's those aspects. So now we have weight. And then the other thing that they never considered were the connective tissue disorders. So they never asked the question, are these patients have EDS or Marfan syndrome, right? So that's why it drops off so steeply from 90 to 38%. But if you control for that. So now, again, instead of using normals, you take the patient who's sitting right in front of you, right? And you say, are you bendy? Like, are you hyper flexible? Well, yeah, I can do this, or, I'm a little hyper flexible. I can do that. Oh, well, when we do the jaw surgery, your chance of getting a cure is less. It's still the best solution for you because there really isn't much else that we can do. We can do some soft tissue surgery, maybe, if the surgery itself, the jaw surgery, doesn't affect it as well. But then now you're doing an informed consent, right? You're getting an accurate explanation to the patient of what's possible. Do I want to go further with the jaws in the EDS patient? Well, then, yeah, probably. But consented, like, do you want a more full face to cure the apnea? And I have patients that say, Doc, I don't care what I look like. I will not use my CPAP again, right? And so I have consent to go further. I have ways of making it look better, right? We can put in cheek grafts to bring this bone out to match the new position, which makes for very strong features, but at least they're balanced, So there are ways to overcome the over-advancement. And then to go back to the initial question that you had, when you come too far forward, do you create lip incompetence? Yes. Well, then impact more. Shorten the anterior face height more in order to get the lips closer together, or do fat grafts into the lips, make the lips bigger, right? So again, make the cheekbones to match here, make the lips bigger to overcome the over-advancement. There are means to overcome the extra push, but it's all functional, right? Mm-hmm. In the end, it's functional. So you want the aesthetic result, make it balance and make it work, and then it's okay. Mm-hmm. Hopefully that wasn't too much of a digression.
No, that was excellent. And Dr. Anil Rama, who actually connected us, hinted right. at something like what you're suggesting here, where he said, I asked him, how would you go about choosing a jaw surgeon or choosing a surgical plan for yourself? And he basically said, never compromise aesthetic harmony when having a plan made for yourself, because you just don't know whether the bigger advancement is going to give you what you're looking for in terms of a functional result. And his big thing is this residual scarring of the brain and of the neurology that occurs with decades of sleep disordered breathing. And there's just no way of knowing whether fixing the box, and even if you can improve the breathing going forward, whether the symptoms are going to reverse given the scarring that's occurred.
So that's great. I love Dr. Rama. Just very smart. Well, everything he does well thought out. So, there are basically three categories I throw sleep patients into. One is an architecture problem or a hard tissue problem. Next is soft tissues, and next is neurological tissues, right? So hard, that's what we're talking about, fixing the architecture, moving the bones, whether it be MARPE expansion, jaw surgery, et cetera, make a bigger box, like you said, right? Second is soft tissue, and we mentioned a few of those things: obesity, connective tissue disorders, but there's also myofunctional therapy. So where the muscles aren't working the way they're supposed to because of anatomical differences and or habits, those can be figured out. I still remember towards the end of the life of Christian Guilleminault, who's like the father of sleep medicine in the world for that matter. But I still remember him coming and saying, yes, jaw surgery is great, but if you don't fix the muscles, nothing works, So it's like he was sold on myofunctional therapy too. So that's another soft tissue component, right? Then you have tonsils and adenoids, another soft tissue component. So then neurological, what do we have? Well, we have the central apneas, right? We have the brain-generated apneas. That's a problem. But we also have peripheral nerve damage, and Christian was also worried about that. He was like, how soon can we treat these kids, right? Like, if we let them suffer with sleep apnea for a time, he was convinced that there was peripheral nerve damage, that the chemoreceptors and the mechanoreceptors that are responsible for blood pressure and heart rate response during these episodes of sympathetic stimulation and not breathing, that was destroying kids, and that you could advance the jaw, 30 millimeters, and it still wouldn't solve the neurological damage that had already occurred. So that's what Rama's talking about, and that's what Christian talked about. And that's the third category. It's the neurological stuff, which is really hard to identify.
Yeah. That's kind of depressing, actually, if you think about it, that there's this irreversible damage that might be occurring, and that sometimes stuff goes offline, and especially with nerves, it's hard to get them back online later. Yeah. Dr. Rama talks about maybe hyperbaric oxygen and other sort of brain hacking technologies that might have some positive impact. But yeah, a lot of this stuff is kind of a one-way path, and it's not a very uplifting message, but there is something to be said, though, for not allowing it to get worse.
Yeah, and I think we're trying. You know what I mean? It's sad, but it's like anything in medicine. Infections were sad too back in the day, and people died from a tooth infection. And now we can take teeth out and give antibiotics, and it's like, who cares?
Yeah,
no big deal.
I think also
so the day will come. We'll figure it out. I think part of the issue is that we're beholden to one of the only diagnostic methods that we have to identify sleep disorders is the polysomnograph. So it's great, but honestly, is it everything? Well, in most studies, when we're studying about airway disorders, we're talking about airway collapse, which is, the critical pressure of the airway closing, or PCRIT as they talk about it in the studies. And this collapsibility of the airway is like everything. But PSG doesn't measure collapsibility at all. And yet that's the foundational architectural functional problem, is collapsibility.
You're saying it can only measure the potential indirect consequence of collapsibility, which is the apnea or the hypopnea, but it's not measuring the actual mechanical that's occurring.
Yeah, exactly. And that's great. It's the best that we have. It's, gold standard now.
But it's really not that great, though, is it? Because don't we get a lot of false negatives from tests that don't measure for RERAs and other disturbances? Don't a lot of people get led astray by sleep tests?
I mean, a lot. Again, we're on the curve again, right?
Yeah.
So most people get identified under the curve. That's why we still use it.
Yeah.
But I think most sleep physicians agree, at least those at universities, that we need to find more. Which is why sometimes, so I can get a sleep study, and in the end, I don't have what I need. So what am I ordering? I'm ordering like a dice, right? I'm going to order where we can actually visualize the collapsing of the airway and what level and how much and whether it responds to advancing the jaw. That's it's a great little diagnostic tool. It is more closely related to collapsibility, right?
Well, you can see the collapsing with the dice. So it's right there in front of your eyes. That's the point, right?
Yeah, exactly.
And when do you consider a dice to be called for? I mean, if a patient presents to you with retrognathic jaws and sleep disordered breathing, is that enough for you to think, okay, a collapse is occurring, or do you want to know for sure before you operate?
I think it's a lot of times it's patient driven. So when the patient's on the fence and they don't know if they want to do the surgery, or they don't trust that the surgery is going to address the issue very well. I just had a consultation and I spoke to the patient. The patient was putting all their eggs in one basket, meaning the jaw surgery. Mm-hmm. And I didn't think it was fair, because there was an enumeration of other processes that were going on that I think influence airway. And the other caregivers for this patient, and then again, let me back up. So this patient had jaw surgery already. So they're coming to me for revision, and the point is like, doc, do the revision and I will be cured. And my point is look, I don't know if you're going to be cured. You have these issues on top of, okay, I can identify, the jaw surgery, they didn't counterclockwise rotate you enough. They really didn't push forward into your lip enough. I mean, I can show that the upper incisor is not supporting the upper lip. So there are positional issues. But I need you to go get a DICE because I need to show you and me that there is a real collapse going on.
Yeah.
And in this patient too, if I showed you their like volume, and I mean, we know that volume and cross-sectional area are not always great indicators either of airway disease. But if you saw his airway, it's like enormous on the cone beam CT volume-wise.
Your last comment, is that because of the radiology and the position that the patient goes into the scanner can often give you a false measurement of the cross-sectional area? Or is it just straight out, you can have a big cross-sectional area and still be symptomatic and still have collapse?
It's all the above. So it's exactly what you said. It's really interesting because Arnett did this study in the 90s where he showed that how you put the patient in the cephalostat. So this is before 3D x-rays. It's just, lateral plane films. How you position the patient in the cephalostat influences the size of the airway and profile.
Yeah.
So we knew this a long time ago. So yes, is the patient breathing shallow? Is the patient swallowing during the however many seconds during the scan?
Right.
And then is the patient in natural head position? Right? Those all influence. And so can I share one more story?
Please.
Dr. Arnett and I, we had the second ICAT in California, cone beam CT. Now there were other cone beam CTs, the new tome, you would lie down and have a scan, right? So I was so into airway, I thought, this is it. I'm going to study airway sizes. I'm going to study airway sizes related to apnea. I'm going to study before and afters of our patients. And I'm going, this is going to be great. So I spend 2 years gathering data. I have a ton of data. Again, Dr. Guilleminault calls and he wants to know how early we can operate kids because he wants to avoid this neurological degradation, right? So he's like, how soon will you operate? Well, let's come talk about it. So we go up to Stanford and we sit down and talk to him. After we talked to him about that, I said, Christian, I have a lot of data on airway size. I want to show it to you. So I showed it to him and he looks at me and he goes, this means nothing. And I was like, oh, this is like 2 years of work, Christian. It's got to mean something. And he goes, no, these x-rays, the patient is sitting upright. He's not asleep. It doesn't mean a thing, And I was like, oh, I guess you have a point. So I took all my data and I just set it aside, which was wrong. I should have published, because it would have beat all airway analysis studies by at least 4 years. And I was like, oh, but I was like, oh, okay, I don't want to bias people to think that airway size matters. But
that's honorable of you, though.
No, it's stupid, really. So all knowledge is good, whether it's it's deciphering. I should have provided the knowledge. All knowledge is good knowledge. So, but that was his point, is it's positional, but not just that. Just like we talked about, if they have a connective tissue disorder, you have no idea what the collapsibility is. And I have seen, for example, I have treated patients where I've advanced their upper jaw 9 millimeters at the upper incisor, 21 millimeters at the chin without genioplasty because of counterclockwise rotation. I've taken their airways from a minimal cross-sectional area of about 70 cubic millimeter or square millimeters to 200, and I've only got their AHI down from 30 to 14. Right? That's disheartening and disappointing. But is it really? I mean, we did something, we got improvement, but I know they wanted a cure, right? Thankfully, this patient was consented that you have a connective tissue disorder. This patient in particular had Marfan syndrome, right? So we knew that it wasn't going to be as effective. So back to the airway analysis, you are correct. It is positional. It is functional. It's how they're breathing, whether they're swallowing, but it is also like you have no diagnosis for what the tissues are actually doing back there.
But what you just said, though, is pretty damning to how most CBCTs are done, even by so-called airway orthodontists and other surgeons, because I don't know any, I've never had a CBCT taken on me, and Lord knows I've had many in my 8 years and counting of orthodontics. Lord, I've never had one lying down. Was Dr. Gimeno saying you need to have the patient lying down to get a good read?
He was saying, so it's pretty funny because when the new tomes came out, everybody was lying down, and it was annoying. They're like, come on, let's figure something out where they don't have to lie down. This is really, and it takes up a lot of room to lie down, right? So we went away from that for convenience sake. But I think his point is well taken. He's not saying that, he's saying that the data is just not as helpful.
Yeah.
The data will show a trend. I'm not saying that. There are two measurements on CBCT that are correlated with AHI: minimal cross-sectional area and the size of the mandible in the AP direction. Those two are the most associated with AHI scores. So
right.
Apart from that, nothing really. Yeah. So it is associated, right? But it's not definitively diagnostic. There are some centers that do MRI. That's lying down. There are other centers that do MRI under propofol, right? So you go to sleep and you get your MRI. You're definitely going to see airway size and collapse when they're lying down on their back under propofol, right? Then they have functional MRIs, which measure the airway size lying down while you're awake. Then they put you to sleep and they measure the differential between the two.
Wow.
But you and I know how much, I mean, that's like, how much does it cost to get an MRI? It's a ton of money, right? These are all just like research-based studies. Yeah. So, I mean, you could do that if you wanted to, but it's just trying to understand airway. And your point well taken. So there's two things, 8 years of ortho, that's a question in the story too. But
there's a whole YouTube channel about it.
I've watched a few. I should probably get knee deep into your podcast and figure out what's going on. But so my point is like head position is extremely important. My staff knows that when they go into the scanner, we have a little cartoon character on the wall on the other side of the room, and they're supposed to keep their head flat to the plane looking forward. And then they have a laser that draws back so that we can see that their head's flat, so that we standardize from one point to the next how people are in the scanner. But I will tell you that there are few and far between radiology locations and clinicians who take x-rays with the mouth relaxed. Most x-rays are taken with the patient biting down into maybe a malocclusion and with their lips together. Putting your lips together in somebody who is long deforms the face. It doesn't just deform the face, but some people put their lips together by having a forward head posture. So it's easier for you to put your lips together when your head's forward. So they can be forward in the machine with the lips together. So it's deforming to the face to have the lips together. It removes all the clinical data of what the real face looks like. It alters the airway positionally, but also having the lips together can alter airway size. And these are really important things that, I still remember at UCLA, my chief year, I knew about, this lips relaxed posture. I needed it to happen. I would walk my patients down for jaw surgery to the radiology department with their wax bite at first tooth contact and insist that the patient relax their lips, and I would stand there. And the radiology tech, because the radiology tech would always just give the same instruction, put your lips together, bite down. And I had to be there to capture what I needed for my data, even as chief resident at UCLA. And it was important. So here's another aspect of airway change. I'll give you another story. And this is where it became clear to me kind of what was going on. So I had a patient that had jaw surgery someplace else, and it was for airway, but also aesthetics. And 2 weeks out of surgery, she calls our office and says, something's desperately wrong. I need you to see me. And I usually don't like seeing patients of other surgeons immediately after surgery. That's the surgeon's domain. Like the surgeon, I trust most of my colleagues to do the right thing, and they do. I honestly feel like everybody's trying their best. And so I think patients really need to go back to their surgeons when they have a problem.
It's like meeting someone else's wife out for a drink because she wants to talk to you about something.
Yeah. Yeah. That's good. Okay. But for whatever reason, she got in at 3 weeks, right? So I'm talking to her. I said, well, why do she said, my airway is worse since surgery. So I did the overlays, and the surgeon brought the jaw forward at Pagonion at least a centimeter, and the upper jaw came forward a few millimeters as well. So I thought, your bones are in a better place. Why is the airway a problem? So I said, describe it to me. She says, I feel like I'm choking all the time. I have trouble swallowing, and I feel like my airway is the size of a pencil. All right. So I put her into the scanner, and I get her x-ray back, and sure enough, her airway is the size of a pencil. But it's interesting because airways don't look like a pencil when they are relaxed. They're ovoid, right? But hers was like this. And what does that tell you? That tells you that when she was in the scanner, she was in this like pharyngeal spasm, that her pharyngeal muscles were contracted. And how would that make you feel if your pharyngeal muscles were contracted all the time?
You're choking.
Yeah, exactly. It would be you're choking. So now the question is like, what is it about the surgery that's causing her to contract her pharyngeal muscles all the time? Well, the joints were not well positioned, and there was some inaccuracy in the jaw surgery. This jaw surgery is notoriously inaccurate, but that inaccuracy caused bite interferences, and those bite interferences caused recruitment of buccinators, pharyngeals, digastrics, So all these muscles are firing because the bite's off and the joints are off. And so like we talked about, the balance between chaos and rigidity, her muscles took over for a problem that shouldn't exist and became extremely rigid. And that was the choking.
Wow.
So sure enough, she waits a little bit. She gets used to the malocclusion. She gets a little bit of a splint in place, and then she loses this feeling that she's choking, right?
Wow.
So she's still off, right? She needs surgery because there's a cant and there's a malocclusion. But at least when she relaxes, the airway is no longer a problem because it's like this. So imagine then you take somebody, most patients who end up in the jaw surgery office have some kind of malocclusion. You tell the patient to bite down, but in biting down, it activates the muscular system. So yeah, guess what? Your airway size is going to be completely different, biting into your malocclusion, which is again why when I put people in the scanner, if the bite is off, I generally have a little like wax bite in the front as they rotate closed, kind of deprogram them to first tooth touch so the muscles can be off. So again, that's how we standardize our x-rays.
Thanks for sharing that. But when the muscles are recruited like that and people are biting forward, doesn't that tend to open the airway? Isn't that kind of like what bruxism attempts to do at a lizard brain level? How do you bring that story to terms with the idea that bruxism is a mechanism, a compensation for opening the airway and preventing it from collapsing.
That's great. So if you recruit your pharyngeal muscles and they are contracting almost in a swallow mechanism, your airway is getting smaller.
Yeah.
It's a sphincter. I mean, it's not a complete sphincter because the pharyngeal is attached to the buccinators, but in many ways it is. And so down low, it'll tighten up and close.
Yeah.
So I love your question about bruxism because we as clinicians, we like to create logical explanations for what's going on, right? And sometimes we fall trapped to logical fallacy.
And as philosophers, we like to do that.
Oh, yeah. I mean, it's what we thrive on, and sometimes it's also good to use logical fallacy to get people to believe that you're smart. So, but we need to accept what we know, yes, but again, science is never settled. So we have to stay open to other ideas.
Yeah.
The way that I learned about bruxism, I learned it from a neurochemical point of view. So what happens when the patient is not breathing is that there's a sympathetic response. So there's a flood of neurotransmitters, and the main neurotransmitters that are involved are epinephrine, norepinephrine, dopamine, and serotonin, right?
Fight or flight.
Yeah, exactly. So all these get blown out, and the main neurotransmitter that's responsible for rhythmic muscle contraction is dopamine. And so what you have is bruxism is not the only thing that we see in apnea patients. Bruxism is one of the contractions. The other contraction we see is wrist flexion. We also see elbow flexion. And so people who have sleep apnea, guess what else they have? They have carpal tunnel syndrome.
Wow.
And they have tennis elbow. And then the other sign, the other is extension of the feet. And so what do they have?
Oh.
They have plantar fasciitis. Right.
Oh.
So one of the main giveaways, somebody walks through the door and they've listed on their medical history, oh, I've had carpal tunnel release. And then they're gingerly walking into the room. You're like, oh, this is a sleep apnea patient, guaranteed.
Yeah.
Because they're in complete muscle contraction. So do I know that this is true? No, the studies are kind of pending. I'm trying to do a study with a guy here in town who's a hand surgeon who does all the carpal tunnel releases in town. So our goal is to do HI, home sleep studies pre-carpal tunnel to see what percentage of carpal tunnel patients actually have undiagnosed sleep apnea. So we're in the process of researching these things. But there's a nurse at the hospital. He walks in his boot and I'm like, what's up? He's like, I have plantar fasciitis. I said, yeah, you're like 80 pounds overweight, lose some weight and you won't have sleep apnea anymore. He's like, I have sleep apnea. I said, guarantee you have sleep apnea. Go get tested. Here, come by the office, pick up the at-home sleep test.
Yeah.
So, so bruxism,
mm-hmm.
We have created this possible, I'm willing to say that this is the protective mechanism for waking up. Sure. And I heard Jeff Rouse preach that in Chicago about 12 years ago. Jeff Rouse, he teaches this triad, right? It's acid reflux, bruxism, and sleep apnea, right? Well, guess where the reflux comes from? So there's two aspects. What's that?
You tell us. I've heard
you said it. You nailed the one aspect, which is pressure, right? Pressure gradient.
A negative pressure vacuuming gastric acids and gastric juices up into the throat. Yep.
But guess which neurotransmitter is responsible for acid release in the stomach? it's serotonin. So you get a serotonin surge. So then why do kids get ADHD who have apnea? I mean, that's the question, right? So when the body is secreting too much neurotransmitter, the body responds by decreasing receptors, right? It's like the homeostasis of the body. You flood the system with more communicators, and in this case, neurotransmitters, then the receiving end, the receptors go down. So what happens is you get a kid, you flood the frontal cortex with epinephrine, norepinephrine. The neurotransmitters, the receptors decrease because of this constant flood. Then you send this kid out into public during the day with fewer receptors. They have ADHD, right? So how do we solve this problem? We give them more.
You flood it more with
amphetamines.
Yeah,
we throw Adderall and Ritalin at them during the day to make up for the lack of receptors. Is all of this true? There's some data that reports that it is true. So wow. I prefer the neurotransmitter axis explanations for a lot of these sleep problems, because that's exactly the explanations that occur in cardiology. So when you talk about stroke risk, hypertension, coronary artery disease, arrhythmia, the cardiologists explain these side effects of apnea using the neurotransmitter model or the catecholamine model in the body.
Wow. So just to clarify the distinction you just drew, maybe it's not that bruxism is about making these tissues erect in order to breathe better. It's just that you have this flood of neurotransmitters, and that's just causing clenching, so to speak, everywhere, all over the body. And it's not really this intelligent adaptation of, or a compensation to open the airway. It's more random than that.
I'm kind of ecumenical until proven otherwise. Yeah. I'm okay believing both.
Yeah.
But I really believe the neurotransmitter model.
Wow. I'll share a maybe related story that's personal to me and part of my own health journey this month. And Lord knows that that's a ever-changing, odyssey for me. But the past 2 months, my headaches have been really awful. Like I'm talking every other day. And these are cervicogenic headaches and facial tension that blossom into like a full-on migraine episode where I have nausea and a desire to vomit. And sometimes I do vomit, and I'll go to bed feeling fine and I'll wake up with these episodes. And so I have a baby daughter now, and I just can't afford to be sick all the time. Thank you. Can't afford to be sick all the time because I have all this financial pressure on me right now, basically. Mm-hmm. So like I told you, I've been doing expansion type stuff for 8 years now. That's a whole story in and of itself, but I'm basically running out of options there. So I have to go nuclear elsewhere. So I've cut nicotine. I've cut caffeine way down, cut cannabis completely, and also cut sugar tremendously. Basically, I'm on a carnivore diet now because I have to be, and because that's the only thing that can get my system to settle down. But what do a lot of these things, especially nicotine and caffeine, have in common is that they're very, catecholamine-inducing drugs. And I would notice that when I would do a nicotine pouch or something, or or have a stiff cup of coffee or an energy drink, I would immediately get these clenchy, spasmy symptoms in my face that felt exactly the way it feels when I wake up in one of these episodes. So since cutting the nicotine and the caffeine, I've been having a lot less of this clenching, even in my sleep. And that, I think, ties into this catecholamine model of where all of this tension is coming from. And I mean, we know that when people do cocaine, it's almost a meme that, they're clenching.
Yeah, right.
So
an MDMA, right?
Yes.
So,
yeah, I think.
That's a great, Ron. That's great that you're vulnerable enough to share that. I mean, that's my prayers and heart go out to you, raising a family. Been there, done that, and Congratulations. But what a great discovery for you with the nicotine and the caffeine. And that often gets, left out in the discussion too. We talk about the stimulants. We can also go down the pathway of other medications. So this also came to light, this neurotransmitter idea, because I found that early in my practice, when I was early on and I was building like the orthodontic side, I still kept open my TMJ myofascial pain side of the practice. And invariably, there were two reasons people ended up in my office with facial pain, with muscular pain. So I imagine that overuse, right? But episodic. So they come in and they're like, oh, my face really hurts. The number one was, let's call it three things. Number one was a new boyfriend or girlfriend. So there's a lot of, facial activity going on. Two would be stress. So we would always have the UCSB kids or the CC kids or the Westmont kids showing up around finals time, right? So they're clenching. But the third is they started a new medication, and the SSRIs, the antidepressants, and the SNRIs especially. The SNRIs are things like Wellbutrin and Effexor, antidepressants, stimulatory antidepressants. These cause insane amounts of clenching. I've seen people start Effexor and come to my office crying because it hurts so bad. Why is that? Because even though they call them selective, they're not selective. They all have dopamine profiles, and they can cause a lot of pain in the thighs and in the face and for bruxism. So again, this neurotransmitter idea fits the model of why SSRIs and SNRIs cause jaw pain and bruxism. Yeah. And there's two sides, and the research is pretty clear. There's daytime clenching, and then there's bruxism or night, sleep grinding. And most of the studies show that daytime clenching is anxiety response. I feel like there could be a malocclusion component in that, but that hasn't been well studied. So then the nighttime aspects are almost invariably related to a neurological disorder or sleep apnea, which is a neurological disorder, right? Mm-hmm. So yeah. Good for you and your path.
Yeah, thank you. I think the hardest part about the connection between dopaminergic drugs, you could say, and some of these pain conditions and sleep disordered breathing is that it's the people with sleep disordered breathing that want to feel good, now, because they don't feel good. Homeostasis Absolutely. Is not good. They don't have this innate pleasure that's in their sort of breath body that they get from just having good posture and feeling alive and vivacious and being able to exercise, et cetera, et cetera. So they reach for that quick fix, which then just puts them in a downward spiral of worsening the condition. And I guess that's how you end up in addiction, right? And addiction doesn't lead anywhere good either. So
yeah, I like what you said, Ron. Homeostasis is not good, and homeostasis keeps us alive, which is good. But sometimes that homeostasis is an excessive energy pathway to destruction. So it's not good. So I mean, it's good that you say that, because what are we willing to live with? And this comes full circle back to orthodontic surgical results. If you take, my partner would always say, I would rather take somebody from and this is kind of, back when people would rate people on their looks from 0 to 10, right? He's like, but let's call it functional anesthetic. I'd rather take somebody from a 2 to an 8 than a 7 to a 9, right? I mean, so you remove so much disability, somebody's really happy with the result. But, the patient doesn't recognize that they could have had a 9 instead of a 7. and that's the homeostasis. Is the clinician aware enough to remove from this homeostatic equation the things that are slowly degrading the patient's health? And we can choose to do that, or we could just go and do what we've always done and get the better result, but maybe not the best result. And the best result requires all of these, like, look at all the things that we've touched on. This requires a really in-depth discussion, right, about a patient's health history and the actual problems that they're bringing to you. And that's why, as well, I run what might be termed a gentleman's practice. That's what my partner calls it. What does that mean? Well, a gentleman's practice is I'm not operating 300 patients in a year. Could I do 300 patients in a year? Yes, I could. But I feel like I would miss out. Like, our consultations generally run 2 hours because this requires a lot of connection, a lot of discussion, and I have to sit and listen willingly to what people are experiencing, because what they are experiencing, they don't have the vocabulary or scientific insight. They might think they do, right? One common complaint: I don't have any room for my tongue. Okay, right? You hear it all the time. What does that really mean? Does it mean there's not enough space? Or does it mean that they're using their tongue as a mechanism to prevent their teeth from touching incorrectly, like a splint? So there's lots of different options for no room for the tongue, but it's my job to listen to what they say, ask further questions, take their story, patient's story, take my story, and then we create kind of our story, which is where we're headed, right? And with planning, and then I present it to them. It's like, here's what you're experiencing. Here are the things that are contributing to it. Here's how you can choose to solve it. Do you always need jaw surgery? No. If you choose to do like ortho only, let's say, okay, well, I was told I could just do jaw expansion. Great. You're solving one of the dimensions out of the 4 directions of growth, and you will, according to the literature, get a 50% reduction in airway problems, and you'll correct your lower teeth. You'll prevent further gingival recession. Your bite will hit vertically instead of off angle. You'll have less, problems in regards with tooth wear. That's going to be a bonus for you, right? Do that. But what you won't get is you won't get lip support. You won't get a bigger airway, a dramatically bigger airway, because we're not coming forward. They will also not put your lips together. But if you're willing to accept that treatment and see how you do, great, go for it and see how you do. Not everybody wants jaw surgery, but it's the informed consent process, which is what takes like the 2 hours. It takes the discussion to explain to somebody, here are all your options. Here's what's going to be offered to you. For example, could I just do lower jaw surgery instead of upper and lower? Yes, you can. But here's what you get with lower only versus upper and lower, right? Not saying one is better than the other. I mean, they are eventually. You enumerate like the risks and the benefits to both, and then the decision's made. Yeah. So that's my job as a clinician. And that's where I derive my greatest reward, is educating people about their pathology and in what's available to them, and hopefully cutting through some of these old wives' tales and mythologies that exist in our profession.
Yeah. You just touched upon the often very complicated or perhaps even complex decision tree that patients have to go through when trying to choose a path forward. I want to go a little bit deeper on one of the decision trees that you touched upon, which is MARPE, jaw surgery, or both. That's probably the most common question I've been fielding through my channel for the past year. And I have some of my own thoughts about it. but I'd love to hear from a surgeon like yourself. Who do you think is a good candidate for doing an expander prior to jaw surgery, as opposed to going right into surgery?
Yeah, that's a great question, and you're right. I field that question like every week, because the referral patterns. Some of my orthodontists are expanders, and some of them are not. And
Totally.
obviously, the expander, the MARPI referrals want to do their MARPIs up front, and I get it. What's my opinion on it? It's diagnostically driven. So to understand it, you have to go through all the reasons why you would want to correct transverse to begin with. So what are the problems with inherently narrow upper jaw or a poorly developed upper jaw? Well, I brought up a few of them just quickly a few minutes ago. So steep palate, a deep palate, V-shaped palate. There is a question as to why it developed that way. I'm not going to get into the weeds. I was about ready to go off into someplace else. Let me stick with your question.
I could go there with you, Lord knows, for an
Yeah,
hour. We could talk
maybe
about
later.
environment versus genetics, but sure.
Well, yeah. So or like tongue tie and all that other
Sure.
stuff. So let me just stick with what you're asking though. So you have a narrow upper jaw. What's the side effect? Well, one is the malocclusion, and the malocclusion, if a particular kind of malocclusion, can lead to destruction of the teeth. So you can get tooth wear. Not always. There's a lot of docs out there saying, well, if you don't fix your bite, you're going to wear your teeth down. I've seen 50-year-old class 3 patients who have fully intact dentitions with very little wear. And so that's not always true. What you have to assess is, what are they doing with their jaws with the malocclusion? That's why all the studies on malocclusion and TMD, and they don't work. Like they don't show a problem. And that's because nobody's evaluating the functional component of the malocclusion. Anyway, back to the story. So you have a bad bite, you can get tooth wear. Because the upper jaw is narrow, the buccinator muscle has greater forces along the lower jaw, which causes the lower teeth to drop in towards the tongue. And then a lot of times there's low tongue posture, which again doesn't resist the buccinator forces. And then you get other issues. So back to the buccinator forces on the lower teeth cave in, the roots push out, you get gingival recession, which then gets blamed on patients brushing too hard. Well, that's not the reason. The roots are being pushed out of the bone and it's thinning and you're getting recession over time. So those are some functional issues, right? Teeth in, bad bite, and then of course we have the airway issues, right? The architecture. So how do you correct it? Should you do expansion or should you leave it to me to do a multi-segment upper jaw surgery?
That's the question.
Yeah. Well, how well can so my ability to do a multi-segment upper jaw surgery and expand the upper jaw to fit the lower depends on where the orthodontist puts the lower teeth prior to surgery.
You're limited by the lower teeth.
Yeah. I mean, well, if you want your bite to fit together in the end, which I think everybody does, yes, I have to put the upper teeth over the lower teeth in their functional occlusion.
And maybe at some point I want to ask you about multi-piece lower jaw surgeries as a potential out from this particular problem, but
sure,
that's a whole separate conversation too. So
okay. So the ability of the orthodontist to upright the lower teeth is sometimes difficult. Some orthodontists are good at it, some are not. If an orthodontist is better at it by expanding the upper jaw first, and like I get to know my referrals, I get to know like who's better at it, who's not as good at it. I would prefer then that they do their expansion prior to allow the lower teeth to be uprighted going into surgery. Does that remove the need for multi-segment? Yeah, most of the time. Some of the time it does. And that's fine, right? So that's an orthodontic technique-driven decision. Should they do expansion? Well, can the orthodontist upright the lower teeth? If they can't, go ahead and do the expansion prior to, and then that's fine. If they can upright them, feel free to leave it to me. I'll do the expansion. So then the next question is, can I do the expansion as well as a MARPE? Well, that depends.
Great. That's a great question.
So I always get the question, how much can you expand, Dr. Gunson? It depends. It honestly depends on the anatomy of the upper jaw. For people who have a flat palate, a broad flat palate, that kind of upper jaw will expand more difficultly in a multi-segment than somebody who has a steep palate. That is anatomically driven, meaning when you pull the segments out, if the segments have this kind of a vector of expansion, then the tissues pull at a 90 degree. The forces are directed 90 degrees across the pull.
Such as on the skin at the roof of the mouth.
Yep. So, but if you are like this and I pull, then the vectors of force are more 45 degrees, which allows separation of the tissues and expansion more readily. So I get more resistance in a flat palate than I do in a steep palate, which means in a steep palate, I can get 10, 11, 12, 13 millimeters, no problem. Flat palate, if I had to get 10 in a flat palate, at that point, I'm like, that's going to be hard to do. And so maybe we want to defer to the distraction osteogenesis of the MARPE, right? The slow expansion and soft tissue adaptation. Okay, so that's the question of ability, so surgical ability versus MARPE. At the same time, then we need to ask the question, what about the anatomic results? So I've heard, for example, several years ago, Audrey Yoon was saying that that with multi-segment jaw surgery, we're not making the nasal cavity bigger. And I went up, I said, Audrey, that's not true. Like my cuts are in the nasal floor and it expands, and I'm literally putting bone graft in the nasal floor. So it's getting wider because I have to graft it. So the nose is getting wider with the jaw surgery, right? I think her point is that in some cases, the MARPE can get a bigger change, especially in the anterior, right? So the piriform aperture, because of the distraction that occurs in the anterior, it can get more than I can get, because at surgery, like I'm not going to put a centimeter here. Like I'd rip the gums out of the face, right? But a distraction osteogenesis of MARPE can get the 10 in the front, right, which leads us to the next question, which is who needs 10 in the front, right? So the difference between a MARPE and a maxillary multi-segment is I can better shape the maxillary arch to fit the mandibular arch than a MARPE can. I can shape it because of the cuts that I make so that I can differentially expand the arch to maintain its arch form, which is pleasing in smile and pleasing in function.
Yes,
okay.
Yes.
Whereas the MARPE, you're kind of stuck with a linear expansion front to back.
If you're lucky. Otherwise, you're getting this, right?
Yeah, right. So, I mean, yeah, who knows how the sutures pop, but let's say that, it works the way that it's intended. You're going to get an expansion like this. So here's what I see that's aesthetically and functionally incorrect then, is when you're doing a centimeter of expansion in the anterior, what do you do with all that space? And the answer is, if you have an arch like this and you do this, you're correcting the space like that. If you do too much in the front, and then you're driving the incisors backwards underneath the lip so that the lip no longer has the support that's aesthetically essential in the middle. So the lips are designed to have the most support right in the middle. And if you're denying that by bringing the arch in because you have too much space in the anterior, then you're creating a functional and an aesthetic problem that is really not easily solved. So that's the dilemma. It's one that I don't think a lot of expanding people are appreciating that they're creating. But on the other hand, the ones that I work with, a lot of them, they are aware of this, so they won't overexpand. I think one of the greatest problems with the expansion craze really is
the expansion craze. I love that.
Yeah, I mean, it's
partially my fault, by the way.
You can never have enough of a good thing, right? But you can, again, just like pushing, you brought it up, right? Pushing the jaws too far forward violates the lips, causes them to have, interlabial gap.
Yeah.
These are problems, functional problems. If you overexpand the upper jaw, either you're left with a crossbite in the lower, or you are going to then do things like SFOT, where you're grafting bone onto the alveolar housing to move the teeth into a position outside what nature kind of gave it. So let's disregard any thought of bone loss. Okay, so there's been no bone loss on this individual. If you're going to upright that tooth and push it out into new bone, what's the functional dilemma? Well, your buccinator muscle attaches below that bone. There's Andrew's called it the Waller ridge, but there's a little ridge you can see along your jawline. That's exactly where the buccinator muscle goes in, and it comes up and then attaches to the same line in the upper jaw. So if you're going to move those teeth out of the bone, you're also moving those teeth into the buccinator, which will affect how your orbicularis oris works and possibly cause dysfunction. But then also you're now moving teeth into a position where they have to fight the buccinator muscle, and they will lose.
Right.
The muscle always wins. So overexpansion is bad aesthetically and functionally, but you put it in the right place, great. So what's the take-home message? If you need to differentially expand, either design an expander that can do that, which I don't think we have just yet, or let me do it, or do as much as you need to get the posterior correct, and I'll fix the anterior, right? Shape and size, and get the right shape and size. So my answer is that it just depends on the diagnosis.
Yeah. What did you mean? What did you mean an expander that can differentially correct? Does that mean an expander that can do more of this instead of more of this?
Yeah. So if in a magical world, if we could program X amount of expansion in the anterior and Y amount of expansion in the posterior, and design an expander that does that, that would be really awesome.
And we would call it a segmental Lefort.
Yeah. But everybody's trying to avoid that. So
right.
This brings up another story.
Not my audience, by the way, but yes, continue.
Well, this is one of my favorite stories. So my partner and I, when we were at the other office, we shared the same, we had our offices in the same room. And he had done this consultation. And the suggestion was upper jaw, multi-segment, lower jaw surgery, right? So then he goes south and has a consultation further south and gets a a treatment plan, which is single piece upper and lower jaw. And he's told all the reasons why. And he calls my partner back on the phone. So they're on speakerphone and he's talking. And the guy's like, I don't know why you would overtreat me. I was told that there are risks to tooth roots and to teeth, and there's infection risks, and the tissue can break down. And he's listing all these complications. And my partner's just cool as a cucumber. And he said, well, that surgeon just told you his entire upper jaw multi-segment experience, didn't he? Right? Yeah. So, and I was like, oh, burn. That's a burn, but it's kind of the truth, right? And I don't begrudge that surgeon at all, because I understand as surgeons, we tend to be only as good as our last complication. Sometimes we let our complications influence what we do, which is good, or sometimes bad. Sometimes it's bad if you don't analyze why it happened and then maybe change your technique so that it doesn't happen again. So what am I getting at there? Well, so in the end, some surgeons don't want to do multi-segments. Like if you go to Europe, very few surgeons in Europe want to be doing multi-segments. It just isn't done.
Does that speak to the conservativeness of the European health system? Like the health insurances there just don't want to pay for that surgery, and it's too risky, or so to speak, to
maybe. I think maybe if you go to the UK system, that may be, but other places that's not as required. Like say in Italy or Germany, where Italy or Spain, for example, that's not so much of an issue, where they can do them, at least within the confines of the insurance that's been given. I think it's just, again, they've seen bad things happen and they read about bad things happening. So why even do it?
Really? Like, I didn't know that. So are you referring to the Italian surgeons? And when you say that they don't really like to do multi-piece segmentals, I didn't know that about them.
No, I mean, it's Europe
in general.
I don't want to pinhole Italians, because I've got 3 colleagues that are my real good buddies from Italy, and they do multi-segment surgery day in and day out. Okay. So it's not them, obviously, but it's like everybody else. I mean, we went to this meeting that was sponsored by my really good friend from Lithuania, Simonas Grabauskas. He's hard to pin down, but if you ever wanted to talk to somebody, he's really just about the smartest person on the planet for orthodontics. So anyway, so he put together this meeting, and he invited both his people that instructed him, which was UK orthodontic surgeons. And then he invited all of the colleagues of Dr. Arnett, the people that he trained throughout Europe. And we all kind of got together. So there's this conglomeration of academics from Europe and the kind of Arnett trained surgeons. And the meeting was like that, where, this one surgeon would get up and say, I can't believe you're doing all this multi-segment surgery. Another surgeon would get up and say, I can't believe you're doing all this counterclockwise rotation surgery. So again, traditional views that were in the literature showing complications, but when done correctly, and when you find out where the pitfalls are, you can avoid them. And so, Arnett and then myself through the years, finding ways to better the surgery then decreases the risks involved. Again, I don't bemoan surgeons who don't want to counterclockwise rotate because they fear the relapse. They know what they're able to do, and they should be allowed to do what they're able to do so that there are not the complications. But it doesn't mean that other surgeons can't do it, and Rebecca Bacau and I, we have this course that we teach together, and we have these t-shirts, and it's a picture of chocolate cake because we talk about chocolate cake. most people like chocolate cake, but just because you call it chocolate cake doesn't mean it tastes good, nor is it something that you want. And it's the same with jaw surgery. Just because you call it orthognathic surgery, it definitely doesn't mean that everybody's doing it the same way. And some of the orthognathic surgeries maybe you don't want. And that comes back to the crux of why you do this. And you remind me of somebody that I knew back in the day who created a means for people who wanted to have jaw surgery to communicate with each other. And the reason he did it was because he himself wanted to find the best surgeon possible. And what he discovered after 8 years of having this ability for people to communicate was that it's really hard to find a surgeon. That was his take-home message after having done all of this. And you laugh because I'm sure you agree. It's like, how do you find somebody? And it's impossible. And my heart goes out to people trying to find the right surgeon, because the surgery is enormously complicated and difficult, and it's fraught with inaccuracy. That's been proven in the literature. Like, as a whole, we're not very accurate in this jaw surgery, but yet we're expected to take 28 complicatedly shaped teeth, make them fit together all at the same time, position those teeth in the bone, in the face, so the face can work, open the airway, and do it manually, like with plates and screws. It's like impossible. When you lay it out on paper, it's like, how could you expect anybody to be accurate? So the surgery is difficult. So it's hard to find both an accurate surgeon, a surgeon who can plan well, who understands function, and they're out there. But yeah, they're hard to find. And a lot of them wouldn't do a podcast with you, right? A lot of them don't have social media accounts. And in my brain, I'm coming up with 4 or 5 people that, like, I would say their names and you'd never heard of them, but they are fantastic surgeons and they do great work. So
would you be willing to share their names now? Or 1 or 2 of them? That would be really valuable, actually.
Well, I did. I mean, I told you about Simonas, right? Simonas Grabauskas is from Vilnius, Lithuania. Andrei Sinuk is from Moscow. Lorenzo and Antonio are from Verona. Most everybody knows about Mirko. Mirko is very good.
Mirko Raffaini?
Raffaini, yeah. You have Octavio Sintra in Brazil. They're out there.
You just broke the internet.
Well, I don't. Yeah, I'm realizing in saying these names now that they might get phone calls. But be nice. Be nice. Julio Cifuentes, he's in Santiago, Chile. Johan Reinecke, one of the greatest surgeons on the planet. I think he's since retired, but he was in South Africa. Just one of the best.
Wow.
Diagnosticians and surgeons on the planet, and just a blast to listen to. The man is hysterical and knowledgeable, and he's a great guy.
These are all people you would allow to operate on you, or
or a family member for sure.
Wow. Yeah, that's incredible. You just listed out. You just doubled my pantheon of potentially decent jaw surgeons. So.
Be nice. Be nice to them. Some of them don't want to be known because they just want to do good work and not be overwhelmed with, referrals and things. But
indeed,
they're good people.
Indeed.
There's plenty others, like surgeons in Costa Rica that I know, and
really,
it's a whole list of really good people. There's in Monterrey, Mexico, there's Alex, so
Alex.
Yeah, Alec, don't.
You'd rather not?
So I'll give you his name.
Oh, sure. Yeah.
Yeah,
We'll take it.
but I'll give it to you later.
Okay, cool. Just as a philosopher, so I keep calling you a philosopher because I believe you are a philosophy major, right?
French literature, but yeah, pretty much. I mean, that's French literature is philosophy. What I studied was, existentialism, naturalism, all of it. It all started in France, which is why I enjoyed studying it so much. I got exposed to a lot of humanity.
Cool. Do you consider yourself a Francophile?
Oh, yeah.
It's funny. My Buddhist teacher was a Francophile too, or is a Francophile. It makes me wonder about France sometime because intuitively I'm not drawn to France at all. I see it as kind of a very Epicurean, kind of hedonistic place, but maybe I'm missing something. And I'm more drawn to austere cultures and more disciplined ascetic cultures. And it may be because of my chronic illness, which has forced me to be more ascetic in my lifestyle. But
makes sense.
Perhaps I'm missing something about France.
Well, I think France, they did really well as far as philosophers, et cetera, until they didn't. I think somewhere around the post-war period, they got a little crazy. So,
which war?
The Second World War. Okay. So, in the 60s and 70s, Jacques Derrida and deconstructionism, I think, kind of ruined things, and the French have a tendency to become hyper intellectual as well. But in the past, these great thinkers, Rousseau, Voltaire. Well, Rousseau, I like Rousseau, but it's not my favorite. But Voltaire and Camus and Sartre, and Pascal. These guys are incredible thinkers and broad thinkers and just good stuff.
Yeah. Thanks for sharing that. Yeah, a friend of mine, actually a person who's helped me set up a lot of these interviews with surgeons, told me about his favorite liquor last night. It's called chartreuse. Apparently it's some rare exotic French spirit that's made out of herbs by monks in monasteries. To me, that's France in a nutshell. But the reason I asked you about your philosophical background was because I wanted to ask, as a philosopher, what do you think about this quest that I'm on to even find the right jaw surgeon and to help people identify what makes a good jaw surgeon and be able to discern a good surgical plan for themselves? Is that a doomed philosophical quest that I'm on? Is there something I'm missing about the sort of the epistemological nature of even asking that question and trying to find the answer? Will I ever find an answer that I'll be satisfied with as a philosopher? What are your thoughts?
Yeah, that's a hard one. I think, it's hard. I go back to my friend who was severely disappointed in the outcome of his multi-year effort. There are different aspects to this. So the dilemma is that you bring to the analysis your underlying bias as to what you want in a surgeon, which is good. You should get along with your surgeon. You should, find somebody that fits. Although, some of the best surgeons are autistic, and you're not going to get touchy-feely from them. And if that's your personality trait, if you're an expressive individual, you're going to be completely turned off by the autistic, surgeon. So,
that's an interesting point.
That's, you have to have, there's a guy in town that I refer to, and I have to warn everybody. I'm like, you're going to go and you're not going to like him, but he's going to treat you the way that you need to be treated. So suck it up. And then most do. And some are like, no, I can't. do that. So we'll find somebody else. But so there's what you bring, right? There's what makes a surgeon good, and I could enumerate a few things that maybe might help you in that regard. I think surgeons who know how to answer the why questions and care about the why questions are better surgeons. I think surgeons that analyze their results, which are few and far between, believe it or not, they're the better surgeons. So I have, for the last 15 years, I've analyzed every surgery I've ever done. We do overlays. We look at midline accuracy. We look at soft tissue outcomes. Did we get what we wanted? If not, why? If the bite's not together, did the joints change? Are the joints in the right position? We analyze every surgery because we want to get better. And in doing so, we have. In analyzing these things, we've changed techniques like crazy to help improve outcomes, and we get better. So if a surgeon's not looking at their results, then good luck. Somebody who answers the questions why, somebody who knows how to work in interdisciplinary scenarios, because they have to have connections with prosthodontists, obviously orthodontists, cosmetic surgeons, etc. They have to be able to work in that environment and communicate well in interdisciplinary. Why? Because as an adult with a skeletal dental discrepancy, you have, and you, I mean, in general, you, not you.
Probably me, but yeah.
Well, you have compensation, okay? They have compensations. They have tooth wear, tooth position problems, bone loss, gingival recession, thinning lips, long lips, deformation of the muscles. All of these things demand an interdisciplinary approach. So if the surgeon is not keen on that, or is kind of like, yeah, I'm going to do my job and then you need to go visit these other people when I'm done, that's not appropriate. You have to work with the entire system, and this almost invariably demands a team. So you want somebody that answers the why, analyzes their results, and knows how to work and has worked in an interdisciplinary team. And then you want somebody that does it more than once a month. Yeah. It's a complicated surgery. So in order to analyze your results and to get better, you got to have actual results. Mm-hmm. And so you need to operate a lot, but volume is definitely not. So for example, I was found to have an opacified sinus when I was in medical school. It was just full of something, and it was found on an MRI. And so I'm like, who do I want to do my sinus surgery? It's very simple. Sinus surgery is pretty straightforward. I thought, I'm going to ask the guy at UCLA that does the most, right? So I did. And he did my sinus surgery. But he also did a septoplasty, which I don't recall having consented to. And it wasn't deviated before the septoplasty, and now it is. So it's like volume is not a measure. You want somebody who does enough, but if they do 1,000, somebody who's running around, I do 300 a year. Well, great. Do you have time to look at your results? Do you have time to talk to your patients? Maybe, maybe not. So volume is important, but it's not key, though people might think that volume is everything.
Well, you think that more volume means more experience, but maybe more volume means less time in the planning stage or in the review stage.
Or post-operative analysis, yeah.
Can you comment with respect to jaw surgery in particular what the danger of volume is And specifically,
Well,
I think custom plates has opened the door to more volume.
Oh yeah. Oh my gosh. Yeah.
And maybe we can talk about custom plates and
Sure.
your use of or lack thereof, pros and cons. But custom plates could allow you to do 9 surgeries a week potentially.
Yep.
But so, what's the where could something like that go wrong if it were to go wrong?
Yeah. So I'm never going to belittle volume.
Sure.
Some people are married, some are not. Some have kids and want to go home at night, and other people don't, and that's fine. No judgment. Like, if you want to do that much surgery and you have the time and energy and you have the focus and you analyze your cases, awesome. Good for you. You're finding meaning in life and you're probably blessing the lives of many people. So that's cool. Where volume becomes a problem, it's the same in orthodontics. I have orthodontic colleagues that are like, yeah, we get, X amount of starts in a week. And that's great. What are your finishes like? So, I don't know. My partner always had a saying too. New technology allows us to do allows us to do what we did wrong in a new way, or what we do wrong in a new way.
Yeah.
And I would say, being fast allows us to be wrong quicker. We'll get it. Let's go into the custom plates in a minute, but we were talking about like picking a surgeon. So volume is important. Too much volume, if it's distracting to the diagnosis, like if it's just like, capitation in medicine, if you have 15 minutes to see somebody and diagnose their entire physiology in 15 minutes, it is just not going to happen in 15 minutes. It's not. So if your volume is such that you only have 15 minutes, then it's probably not enough, so if your volume impedes diagnosis, if your volume impedes analyzing your results, then that's the problem. It's the choice of how you spend your time. So I think that goes back to the picking the surgeon aspect.
Right.
Go ahead.
Yeah, just a quick question about diagnosing as a jaw surgeon. Jaw surgeons, they're not like other physicians where there could be a variety of treatments that are presented as options, or it's not even clear that jaw surgeons are necessarily doing a lot of diagnosis. At least from my experience, they're mostly, the patients have already come in with the diagnosis, and the jaw surgeon is just deciding, yes, we'll operate, or no, we'll not operate. And then given a certain structure that a patient presents with, it's like, well, no matter what, you're going to make it as beautiful and as functional as possible. So I guess it's not clear to me why a jaw surgeon really needs 2 hours with the patient when it's more like yes or no, and then this is what I'm going to do pretty much no matter what. What am I missing?
I think it's the difference between the artist, the engineer, and the healthcare provider. So an artist makes something beautiful, but because they're an artist, they have a difficult time of explaining to you how they did it, right? Because it's art. And a lot of surgeons call themselves artists because they don't want to have to explain or can't explain what they do. The engineer is able to explain what they do, and they work within the confines of the structure. And then we have, there's another group. It's like the mechanics, right? Patient comes into the office, just like you bring your car in. The mechanic opens the book, puts the little plug into the electronic output. The car tells them what's wrong with it, and then they fix it, right? And then you're on your way. Is the car any better for it? Well, if you brought a Dodge in, you still have a Dodge. Okay. Did you want to bring your Dodge in and walk out with a BMW? If that was your intent, you're not getting it, right? But with jaw surgery or health, in many senses, you were bringing in a Dodge and walking out with a BMW, for example. So that moves us into kind of the engineering phase, where you start to ask questions about like how all the parts interact with each other, and you're going to provide a better solution for how they interact with each other. But then you get to health. And health is about assessing somebody as a whole, because this is where I think the philosophical side of things kind of benefits me. I hated dental school because I am a broad thinker. I can assess large things, and I like putting things together in large systems and explaining systems and how they interact. Dentistry required me to focus on something really small and to solve a really small problem, and to really disregard whatever else was going on. Fill the tooth, take the cavity out, fill it, call it a day. There was very little, like, why does this cavity exist here to begin with? There are people that study that, right? But that's health, right? So yes, the jaw surgeon can run their practice just as you explain. You come in, yes, jaw surgery, no jaw surgery. Yes, jaw surgery, this is what I'm going to do. Thank you very much. And not get involved. And in many respects, it's a very safe place to be. But for me, that's very unfulfilling, because I have a person that I can get to know. For example, so I had a consult on Tuesday, and immediately I knew that they weren't there for jaw surgery. Like, they were kind of referred thinking that the jaw surgeon might be able to help. But in the end, what I was dealing with was a pain patient who had seen 10 different doctors over the course of like 10 years, who had had 3 splints put in her mouth without any result, who had been on a bag of medication, cycling through different medications, trying to solve a problem. So I could have ended that appointment. I could have just said, look, your jaws are in the right place. Your bite fits together. I got nothing to offer, right? Because I'm the surgeon. And I do tell them that. I'm like, this is what I do. But I'm also a healthcare provider. So do I provide health care then? Well, is the face in the realm of my expertise? Yes, right? So I am okay thinking outside of jaw surgery, though that's what I do. And I choose to. So I choose the health. And so on this patient, I'm able to identify posterior interferences, anterior compensations leading to posture and speech problems. I point out the position of the tooth problems. I point out which muscles are hurting. I point out that her jaw joints are actually okay. She doesn't have a jaw joint problem. But in the end, she did have a connective tissue disorder, which I diagnosed. I hand her the handout that I have on Ehlers-Danlos syndrome. She reads it. I come back into the room and she's crying.
Wow.
And I'm like, well, what did I say? I'm sorry. What did I do this time? Well, she said, you have handed me something that describes my entire life, but not just my own. This is my son's life, who is, 17 or 18 years old. And while a diagnosis of like Ehlers-Danlos is difficult because it's chronic and there's not a whole lot you can do to, quote, cure it, there's a lot you can do to live in it. But what's more important is for the patient actually to walk away thinking that they're not crazy, because they do get told that they're crazy by physicians because of the spectrum of disorders. So and then what does she say? She says, I feel more seen today than I ever have been seen in my life, right? I could have walked away. I could have said no jaw surgery, but instead I've now provided health care. She gets a sleep study. She goes to the orthopedist. She goes to the Pilates instructor to strengthen her core to overcome the fascia defect. So now she's living, or potentially going to live, a different life, a healthier life without jaw surgery. I get paid for my consultation and that's it. But I walk away feeling like I'm a better human being. So you run your practice how you want. It's fine. I choose to do it this way. And it's rewarding for me. But again, it's a gentleman's practice, and I'm never going to have the mansion on the hill in Santa Barbara, which is fine too. I mean, I live in Santa Barbara. It's pretty awesome. I'll never bemoan that, right?
Yeah.
But I'm not in this for that. I've found where my heart is, and that's in healthcare.
Yeah. Yeah. My Buddhist teacher used to say that when we die, we have to pack light on that journey.
Right.
And you're certainly not taking a mansion in Santa Barbara with you, but you are taking your good deeds. So
hopefully, yeah.
So sure, that's
definitely leaving it behind, right?
Definitely leaving it behind.
Hopefully you've helped somebody improve themselves. So
now that way of practicing medicine that you just described, does it often translate to a better jaw surgery too? Like, do you, in that 2-hour discussion, maybe you diagnose the EDS and you realize, shit, 2-centimeter mandibular advancement is not going to be the magic bullet here. So maybe we take the more balanced approach that's a little bit aesthetically balanced and conservative. We realize that the bony advancement is not going to be a cure-all. And so this is the type of thing that comes up in a 2-hour conversation that translates actually to a more aesthetic, more functional jaw surgery.
Yeah. I mean, well stated, well said. And does it result in a better jaw surgery? It results in a better outcome for sure. So expectations are set. Patients make decisions based on maximum information, which leads to less disappointment after the fact, right? And then, discovering the disabilities that they inherently have that are functional, which maybe won't be identified elsewhere, allows for a greater sense of health and a reduction in energy usage post-surgery. So again, a lot of this energy usage that causes the system to degrade is time dependent, and they won't see it for 10, 20 years, but they will see it. And at the time that it happens, guess who won't get the blame? Me.
Yeah.
because I'm gone, and it's temporally so distant that nobody's going to blame it. Like, Dr. Gunson didn't get the lips together.
Right.
And that's what caused this problem 20 years later, the clicking and popping that developed in the joint because the lips aren't touching. Nobody's going to blame me for that.
Yeah.
And
just to be objective about it, how much time do you normally spend actually sitting at the computer and drawing up the new face for a patient?
Not a lot. I mean, comparatively speaking, it's mostly listening and educating. Knowing where the parts go is pretty straightforward. Upper tooth belongs here, the bite belongs here. The sagittal rotation of the jaws puts the chin and the nose here. The vertical is defined by upper jaw, lower jaw, overbite correction in the chin. Get the vertical correct, boom, you're done.
And are you basically eyeing that out? Are you using your gut when you look at the computer?
No, it's all measurement based. So we go back to where the upper incisor belongs in the face. You could use all those analyses, or you can measure it. And how do you measure it? Well, you put something behind the upper lip until the upper lip is correct in its projection and its function. And that's where the upper tooth belongs. Is to support the upper lip. That's measurable. So I do both like what we call digital consultations, so telemedicine. I do in person. My hands are a little bit tied with the telemedicine because I can't physically measure where that incisor belongs. And this is what I tell the patients I'm talking to. They're like, especially the internet-based ones, they're like, well, exactly how many millimeters are you removing my upper jaw for? And it's like, well, 7, 8 is my best guesstimate, not seeing you. But when you are here in person, I will find what fits best in your face. And we can judge that both for lip support as well as orbicularis oris function. So that's measurable. It's just in-person deal. So hopefully that answered.
Is there some calculus that you do mentally to try to anticipate a variability in how a specific person's soft tissue could react to a bony change? Is there a software you use to do that, or is there just mental software based on experience, based on a person's skin type or something like that?
Again, it's physical. You physically put something behind the lip. You can choose to put moldable wax. You can choose to print 3D. You can replicate the teeth in a more forward position and in a 3D print job and stick that behind the lip. You can simply take a dental mirror and push behind the lip until the lip looks good. It's a very individual measurement, but you have to make it by putting something behind the lip, just as you would by doing the surgery when you're putting the jaw behind the lip. So that's the take home. Do I use the Arnett analysis, the Steiner analysis? Do I use the Barcelona line? No, I don't. I measure each individual patient's capacity to support the most anterior position for the airway without violating the orbicularis oris, and that's a measurable distance behind the lip. At least that's my opinion.
To segue into custom versus non-custom plates, someone told me, and this was not a surgeon who said this to me, so potential for bullshit high. He said that one of the benefits of non-custom plates is that when you're actually in the surgery, the patient's on the table, covered in the sheets, and the jaws are moved, one of the benefits is you can actually see how the soft tissue is reacting to the movement that you had planned, and you can call an audible potentially and say, you know what, maybe not so much, or maybe we were off on the height adjustment on the tooth a little bit, and you can bend around something you discover in the field. Is that valid, or is that not actually ever happen? And of course, with custom plates, you're stuck. Well, sort of. You're not totally stuck. You can work around the plates. You can drill different holes than what the templates tell you. If you're experienced enough, potentially, maybe not. I don't know. But yeah, please comment.
What that surgeon said is true. But
non-surgeon. He was not a surgeon. He was he was a highly.
Well,
he was a smart lay person.
It's somewhat true. So it's somewhat true in that that can be done. The question is, do you want to be doing that? And the answer is not really, because your ability as a surgeon to alter a plan in the operating room, I mean, you know, the 3D planning goes within 1/100th of a millimeter. You know, these splints are fabricated within 1/100th of a millimeter. Not that we're that accurate, because we're not, but why add inaccuracy? So we measured to the 1/100th of a millimeter. And then if you're eyeballing something, I mean, really, if you're really good, your eyeball can manage about 1/4 millimeter, maybe 0.2 by itself. But then that structure in the face, I don't know, you're talking really large error. So not great. You don't want to be calling the audibles in the OR, which I try not to do any audibles. My plan is my plan, and I trust my plan. So now, I mean, you want to have the custom plate discussion. There are other aspects, but we could start with the data. So we can start with the study that was done about custom plates, which was done by Ed Ellis. And what he did was he was able to show that residents in the operating room were more capable of achieving an accurate result with maxillary positioning using custom plates as opposed to a splint and bending plates. And that those were the residents that were doing the surgeries. And so that's great, right? Why wouldn't you do custom plates in that scenario then? If a resident could be better and more accurate, then awesome. But I'm not a resident. So do I need a custom plate? Well, then I have to ask the other questions about custom plating. So what are those issues? Well, custom plating is based on the DICOM. And the DICOM file, which is your X-ray file, has a certain voxel size. So that's the resolution of the X-ray is defined by box volume. And the minimal box volume that usually you get with CBCT scanners, you can get as low as 0.2 millimeters, cubic millimeters. But usually it's like 2.5 or 3, sometimes 4, depending on the settings of the surgeon. On top of that, you have the definition of the surface. So not only is there resolution of voxel size, you have the definition of the surface, which is defined by how much energy you're using with your scanner, which is radiologically, it's called milliamperes, so MAs. The higher the MAs, the more definition you have, and the more variation you get in density from the hard to the soft stuff. So that's like a grayscale. So the higher the MAs, the better the grayscale, the better definition. Now, your custom plates are designed by taking that DICOM and turning it into a surface file. That surface is defined, again, by voxel size as well as MAs. And then the computer judges what that surface is. And then the plate is designed onto that surface. So you go from a volume to a surface file. And then that plate goes on the surface. And that's how it works. And you can design plates and put the screws, the really cool thing is you decide where the good bone is, which is always a problem in upper jaw surgery. You put the screws where all the good bone is, and then you don't have to worry about like finding bone with your plates bent. But you're beholden to two things with a custom plate. You're beholden to the engineer and the tech's ability to segment the volume file, which is basically deciding the threshold of the density and the resolution of the surface. And I've asked engineers and they say, hey, it's pretty good, so I'll go with it. Sure, it's pretty good. But then the second thing you're beholden to is that the physiology of the body allows you to do what you plan. So that's the second step. And I think that is an important one that, is the occlusion, for example, that you're going to establish going to change the vector and movements of the bones in the exact same way that your splint and or your occlusion is telling you it's going to. And I think that's where a lot of the variability is. And so if you get inaccuracies, that's where it's going to land, at least in the upper jaw.
Those are interferences?
Well, interferences has more to do with resolution and definition, so how the surfaces meet the surface.
Right.
The second is the physiologic movement of the jaw.
Musculature or bone?
No, just vector of the bone movements dependent upon where you're putting it in the face.
Okay.
So, and there's muscle resistance, right? So if you had some muscle resistance, maybe it's more difficult to make the jaw go to that position. That's technique driven, and we can talk about that. But so those are the two main things in the upper jaw. Now there's custom plates in the lower jaw, which, again, personal bias, like I would never do. And the reason is because you're beholden, number one, to the record that you're gathering before surgery. So the patient is awake and brings to that appointment all of the posturing of their jaw relative to their bad bite. And you are asking the oral surgeon, or maybe the assistant, I don't know, or they're disregarding it altogether and having the patient bite down in the scan, or with the lips together, which we've discussed, which would displace the jaw joints, even a small amount. If those jaw joints are in a different position in the office than they are with the patient on the table, and you apply your custom plates, your surgery is wrong. Because the jaw joints will seat post-surgery. So that's comment number one. Comment number two is the jaw joints, or the proximal fragment of the lower jaw.
This part right here, the back part that's
the back
connected
part
to the joint.
Yep. That part never stays exactly where it was pre-op. If you always maintained the proximal fragment exactly where it was in the office and advanced the lower jaw, for example, that lower jaw is going to interfere here, and the angles, which are in a more in position relative to the front, now you're taking the front and bringing it forward, making it wider relative to where the angles are. That if you leave the angles where they are and advance the jaw, they're going to have this really square face here in the front with the angles being in.
Almost like an MSDO type movement.
Yeah, so this front just gets big and this stays put.
Right.
So always those proximal fragments change slightly, not so much as to cause compression or damage, but they change. And to think that the surgeon knows exactly how that proximal fragment is going to be positioned at the time of surgery, given bone interferences and muscle situations and a host of other things, ligament laxity in the joint, how the surgeon actually holds the proximal fragment when they put the hardware on. Like, even for me, I've analyzed if I hold it one way versus another way, it's different. So actually, right side versus left side, different. You have to be aware of all these little intricacies of how things change. So the chance that your joint on your 3D planning is exactly where that joint's going to be in the operating room is close to zero. What are we talking about, though? Are we talking about 1/4 millimeter, 1/2 millimeter, 1 millimeter, 2 millimeters? We're probably in that scenario only talking about a couple millimeters, right? I mean, honestly, and in fact, if you look at jaw surgery, the average inaccuracy in positioning the lower incisor at surgery, the acceptable average inaccuracy runs between 2 and 4 millimeters.
That's absurd.
I agree. But we accept it. We accept it so much that the articles that are published won't start counting inaccuracy until it reaches the threshold of 2 millimeters. So am I willing to live with that? Well, I am not personally. I couldn't live with that, both because the bite fitting together won't tolerate 2 millimeters of inaccuracy. And at that point, the surgeon doesn't care anyway. They're like, here, orthodontist, you fix it. Which is unfair. But so without custom plates at all, as a whole, surgeons are very inaccurate. With custom plates, maybe more accurate, but at the same time, there's always going to be a discrepancy. And if you take on the average, maybe you're better with the custom plates than you were without them. And that's great. You recognize that that's the case. You do it that way. In my hands, I would not tolerate that in my brain or as a result. So I have an entire technique of applying plates, how I apply plates, what the physics is of tightening a screw, the order of the screw, how the screw engages the plate, where the plates go in the osteotomy, where the screw holes go, how I hold the jaw joint, how my assistant retracts the tissues when the screws go in and when the jaw joint is seated. These are all aspects that influence accuracy and inaccuracy, all of which we control for. So like I said, I've studied it all. Our average inaccuracy is about 0.4 millimeters. But our voxel size when we did that study was 0.4. So we are somewhere in the realm of the ability to actually measure our inaccuracy. The best part about it is when I did that study and I applied a lot of the things I'm talking about. So I looked at before making changes and then after making changes technique-wise. The standard deviation dropped immensely. So the standard deviation or the plot scores on this side were really varied. On this side with the techniques, the standard deviation was so much smaller. So that is also a sign of accuracy. Okay, so what am I saying? If you're better using custom plates, use them. Great. And better meaning more accurate and able to achieve what you plan. Okay, that's great. Use them. For me, nowadays, as you would imagine, everybody's asking Dr. Gunson to use custom plates.
My fault.
And my answer, I jokingly, I always say, yes, I custom bend every plate, to your position, to your jaw position. Why? I love bending plates. I mean, I can bend them, and I understand. There's a whole understanding. When you've done it long enough, you know how the jaws move. You know where the zone of bone is. You know the shape of the plate. The plating system I use, they're not right angle like L plates. They have a very specific curvature to them that is made to actually align with where the bones are. And then I know where the bends are. I can actually look at the gap, and I can bend the plate and then try it in, and I'm pretty close. And then it's about micro adjustments at that point. So I feel good about what I'm able to do, and that's me. And I will continue to do that. Now, I've had a case that I did where I used a custom plate in the upper jaw, and I did it because her bone was so horrendously bad. I had no idea where I was going to put a screw.
It was thin. The bone was thin.
Yeah, the upper jaw bone was really thin. She's 50-plus-year-old female with osteopenia, osteoporosis.
So definitely not a multi-piece segmental candidate, because the whole thing could crumble with bone like that, right?
Yeah. Okay. Yeah. So then there were a few other reasons: hypermobility, jaw joint placement at surgery, lots of things. And so I thought, hey, I'm just going to use a custom plate and try this out. It was actually my first one, and it was fun. It's fun. You just put the templates in, and then you take that plate and you put it on there, and it drops on there, and then you put your screws in, and it was great. But that's it. Everybody else, I really don't have a problem bending plates. Yeah. If you do, then fine, go get a custom plate. The other thing is with my practice, I get referrals from kind of all over the US and the world So they show up on a Monday for surgery. Am I going to ask them to then come back in 3 weeks when their plates are done? Yeah, I would have to if I did custom plates. But in this way, doing what I'm comfortable doing, a Monday workup can have surgery Wednesday, Thursday, or Friday without delay.
Yeah.
So they stay in town, they don't go anywhere.
That's
and
interesting.
they can have their surgery.
It's a logistical benefit to non-custom that I hadn't considered, but that's very real, especially given the type of patient that I often interact with, which is an international patient. Do you think that your virtuoso sort of level of working with non-custom plates, bending plates, are you drawn to the craftsmanship of bending plates rather than the plug and chug nature of custom?
No,
because of your this more holistic approach, non-mechanic approach to being a doctor?
I love it. No. It's some of
like Daniel Day-Lewis is a cobbler.
Sure. Well, the best advice I give my kids is choose your pain. This is Buddhist thought as well, right? Choose your pain. Life is pain. Choose your pain. It's going to be painful. Just choose what pain you're willing to live with. If I didn't have to bend any plates, that'd be great. I don't enjoy bending plates. I mean, I can do it and I do it well and I do it fast and it's fine. If I didn't have to, that'd be cool. Because there are some days when that plate looks like something out of a modern sculpture with twists and turns and things that doesn't make any sense. But anyway, that's a pain in the butt. If I didn't have to do it, I wouldn't do it. But I choose my pain. I choose to do it because the pain of having a bite that doesn't fit together, or a pain of the midline being off of the face to the left or to the right that I have to look at, until the patient's discharged, is not worth it.
Wow.
For me. I hate it. I don't want to live with that. I don't want to deal with it. So I choose my pain.
To what degree are your critiques of custom plates inherent to the technology, as opposed to things that can be improved upon as the technology improves? I think your first criticism, maybe as the scanning technologies get more precise, that could get better.
And I believe that the scanning technology is pretty good, and the plates probably fit most of the time really well. Because we used a lot of custom plates in trauma and in pathology in residency, and they fit great, and they were really easy to work with, and they changed a lot of how we reconstructed people, and it was really helpful and lovely. So I'm just saying that is an area of error, and how much is it? I don't know. And technology will improve.
But second critique, which is
that's the one. That's not going to be solved anytime soon,
because it requires there's this complex relationship between the jaws and the rest of the tissues in the face, and you can't really know what the other side of the equation is going to look like until you actually manipulate it with your hands during the surgery. There's no
or how the patient's going to react to. So if you're doing your 3D planning and you manipulate the proximal fragment or the joint into a certain position, you really don't know if the patient's going to tolerate that or not. Like, is the patient going to tolerate having their joint torqued that way? And they might 68% of the time. So they might land underneath that curve, which is fine if you're willing to accept 68%. But again, I choose my pain. I want 0% if I can do it, and I can, and it doesn't hurt me. So and then people say, well, AI is coming, as if like AI is going to solve all our problems. Well, AI, guess what, is not going to solve all your problems, because AI derives data from existing data points. And our existing data points are trash, as I've explained. they're trash. So if we're going to create AI structures based on past surgeries where we were willing to accept 2 millimeters of error, guess what AI is going to do for us?
Yeah, shit in, shit out.
Yeah, it's going to give us 2 millimeters of error and be happy with it. And we're going to be happy with it, and you're going to take it, So it's, now if we can program AI to help us understand how the joint is going to respond to our surgery, and we have an open enough mind to ask AI these kinds of questions, as opposed to what's the best spot, you're in the end asking it to come up with an idea of how the joint is supposed to function and what it's able to tolerate. Then at that point, yeah, maybe that's going to be awesome. And I would welcome that with open arms, because the last frontier of jaw surgery is those freaking joints.
Mm-hmm. What do you think about these 5 or 6 piece mandibular surgeries as a way of widening the mandible so that you can get a bigger expansion and widening of the upper jaw, and how those surgeries manage the joint specifically? Yep. Supposedly with all those cuts, you can relieve the joint by dealing with that, this movement of the proximal segment that can occur. Or maybe I have no idea what I'm talking about. That's probably it. But
no, I mean, I don't think cutting the lower jaw into segments is going to influence positively joint placement. It's the same problem no matter what you do with the lower jaw. So I think what we can talk about is we can talk about non-surgical expansion of the lower jaw. Well, sorry, not non-surgical, non-osteotomy. Well, that's not it either. Why don't we talk about distraction osteogenesis, which is midline distraction of the mandible.
Okay.
So midline distraction of the mandible, does that work? Yeah, it's great. I've done a number of cases. The question is, what's the diagnosis? So in those patients, they had an actual narrow basilar bone. So the basilar bone was narrow, not the alveolus and not the teeth. So the teeth can be narrow. They can be bird-beaked, where the alveolar bone and the basal bone are more rounded. In that situation, you just put the teeth in the basilar bone and you're fine, right? But in a situation where the basilar bone is V-shaped, then yes, you can stand to do a distraction osteogenesis, where you expand the front. You make the chin wider, which is aesthetically pleasing in people that have pointy chins. It does torque the joints. Patients will get clicking and popping, but like the joints, the joints of most people will adapt functionally. The ones that'll kill you are the ones that adapt dysfunctionally and resorb, right? But then you need to know how to pick those patients. So it's like, should I be doing this on a high angle class 2 female who has irregular periods? And the answer is no. Don't, you're going to cook their joints by torquing them.
Interesting.
So then the question becomes, well, how often do I make the diagnosis of the basilar bone being narrow? And the answer is few and far between. So I think the mandible as a whole, given its embryological origin, grows really well. The tongue dictates usually the growth of the mandible embryologically and fetally. And without significant genetic compromise to those processes, the mandible generally grows well. Now it can grow asymmetric. It does that all the time. That's a different story. And then the joints can get smaller, which then that's not really a basilar bone problem. That's a joint problem.
Would you say the mandible is more likely to be short than it is to be narrow developmentally? Because we see a lot of short mandibles, don't we? Or are they just buried in the neck because of a recessed maxilla?
Yeah, so I think many jaws, if you had to pick, most jaws are high in the United States. Most jaws are high angle jaws, and they are retruded. If you go to Poland, though, you've got really broad jaws that are severely retruded. So you have the class 2 division 2s. And, for a guy that made his name talking about condylar resorption, showing up in Poland to talk about condylar resorption is a waste of time. Their population is like class 2, div 2 broad jaws day and night. So I don't take those lectures to Poland. So it's racial, societal, depends kind of the situation. You have certain parts of China, very, very class 3 hypo, underdeveloped maxillas versus the Japanese. So just off the coast, who have a lot of Chinese influence genetically, yet a lot of them high angle class 2s with joint problems. It just depends where you go.
Yeah.
Having said that, it's like, so who needs the distraction? Well, the narrow jaws, and they're few and far between. I can't speak at all to multi-segment mandibular osteotomies. Never done them other than a midline split. I've done a BSSO with a midline split. I've done a few of those. But usually those are not necessary. If you pre-plan, they're not all that necessary. Like, I haven't done one in a while, but also the interventions of, what can an orthodontist do early on in childhood development? Well, they can expand the upper, but they can also facilitate lower jaw width as they intervene with lip bumpers and buccal bumpers and things like that, and myofunctional therapy, and allow the jaws to express the growth that is intended. So those are scenarios where that happens. But I'm definitely not the guy to pontificate on any kind of multi-segment lower jaw surgery with BSSO other than a midline split. And I've done a few.
Yeah. Yeah. Is it the case that more plates, such as a surgery like that requires, means, do you think that the risk of infection is that the big risk with something like that? Or would you be more concerned with something like potential TMJ fallout? Or is more your points just saying that, is it really necessary to be doing these multi-piece mandibular surgeries to widen them?
I think that's the question.
Yeah.
Is the deficiency such that we're correcting a real problem? And I will admit that based on how I see the lower jaw, and I'm willing to be wrong, or I'm willing to be biased or accept my bias, for example, that I'm not seeing it correctly. But in general, I think that the lower jaw tends to be correctly formed in a basal position, transverse.
Yeah.
And so it doesn't require that kind of effort. What would I be worried about? Stability, healing, the number of plates. I don't, with infection, probably not so much of a problem. Yeah. But I think stability is the next question, because the mandible receives all kinds of forces that need to be accounted for.
Right. Doctor, we're approaching 3 hours. I'm going to let you go. I just have one last question for you, if it's okay. Can I jump into a screen share real quick to ask?
Sure, and it's up to you. I don't have anything until 11, so I got another 30 minutes if you want it.
Oh, okay. All right. Well, why don't we start with this? So this is a question about genioplasty. The question here is there a right way or a wrong way to doing a genioplasty, specifically one which is airway beneficial as opposed to one which isn't? And the images that I will show you are this one, which is potentially the normal sliding genioplasty, that the person who gave me this question to ask you is thinking maybe this is not the best way to do it, as opposed to this one, figure B, which shows this here, which could potentially be more airway beneficial by pulling the hyoid bone and other structures forward along with it. What are your thoughts?
I wish I could be. I can't see them.
Oh, you can't see? Mm-hmm. Crap. Yeah, this is...
I see white. and it's blinking. So it's almost like it's supposed to be there, but I don't see it.
Can you see it now?
No. I can address the idea of genioplasties if you'd like, but I think I understand what it is that you're asking, so we can talk
Yes.
about.
Why don't you go ahead and I will work on figuring out this software at another time.
Okay, no worries. So I guess we start with the question, what's a genioplasty for? And to answer that question, we need to ask the question, what's the chin for? Like, what's the purpose of the chin? And that's debatable. Anthropologists, I've heard some anthropologists say that the chin's a vestige, which is interesting. But at least at present in modern jaw development, the chin position allows the lower lip to function in such a way that it can close and interact with the teeth in the proper vectors. And so that chin point gives projection to the mentalis muscle for it to do its job. And so, as such, it's all about, again, getting the lips together and lip function. So where does the chin belong? Well, when we do a genioplasty, it's because when we're done positioning the jaw bones, AP vertical and sagittal rotation, so clockwise, counterclockwise. If the chin is deficient, you can bring it forward. If the chin's too far forward, you can set it back. If the chin's too long, you can shorten it. And if the chin's too short, you can lengthen it. All of that is dependent upon how the lips come together, which in the end is the most aesthetic position for that chin point, which is aesthetically, is I think most people would agree, upper lip in front of lower lip in front of chin, to the tune of 1 or 2 millimeters between them. All right, so that's when to move the chin. How you move it depends on its volume and its overall anatomy. So if, for example, the chin is short and, for a lack of a better term, hooked so that it hooks up, it will expose the body of the mandible as the structure that's most visible, creating a very square face. So you can take that chin and cut it. So do you want to cut high or do you want to cut low? Well, what are you trying to solve? If you're just trying to solve the button position, then you will cut across where the button starts or the projection of the chin is. And then you will lower that portion of the chin, which will help you have a better looking, what we call B point, or this, recessed area underneath your lip. So you can alter the level of the osteotomy both for what is moving here, and then you alter the length of the osteotomy for how much expression of volume you want to occur further back. So in some scenarios, you want to express volume here, but not here. And other times, like with narrow people, if you carry this further back, and as you bring it forward, then now as this comes forward, you're expressing more volume in the front, or on the sides here, which makes for a squarer, bigger jaw. Question is, does the patient want it, or does it look good that way? That's why sometimes you may have heard of the chin wing procedure, for example, where they take that chin procedure all the way back to the jaw and then advance the entire inferior border of the jaw. Well, that looks great in people who have very narrow jaws because you're bringing it all forward. But, there's a ton of risks with that procedure we don't need to go into. But that's the idea. The further back you go, the wider it gets as it comes forward. The tighter the cut, the less width you're generating behind it, which sometimes you want in a patient. So that's some example. And then, of course, you're kind of beholden to where the nerve is. And the nerve exits the foramen, but before it exits the foramen, it has a little curlicue underneath it. So that drop of the nerve canal, you need to avoid that, which can drop. It can kind of dictate where that cut goes as well. All right. Well, what about airway? So if you take all that into consideration aesthetically, what if you make your cut higher so as to include the genioglossus, right?
Yep.
The genial tubercle. Well, here's where there's a lot of debate. So I know plenty of airway surgeons that do their Genioplasty advancements by cutting chins high. Okay, that's fine as long as it looks fine. If you bring a chin forward, cut high, and you end up putting the bone underneath your tooth in a more forward position, it's going to look funny and function funny, because now you've put bone into the area of the mentalis function, and that's not a great solution.
Yeah.
So then there's the other solution, which is doing the old version of the Genioplasty advancement, which is cutting a window around the geniotubercle, advancing it, and removing the labial bone over it so that you pull the geniotubercle through the bone, the cortex. You get about a 10 to 12 millimeter advancement of the geniotubercle. And that works well without really deforming the chin in many respects. And Genioplasty has been shown to be pretty helpful. I mean, we're talking maybe 10, 20% of folks that get successful improvement, that 50% reduction. And then there's a question about relapse, actually. So I don't know the data on relapse, though. Some of the stuff I read was that it relapses a bit. So I think that's kind of my take on chins. I operate chins for function, and then the ultimate aesthetic result is great. So it's both. Now, there's a lot of leeway here, right? So you get a patient who's like, I don't want a strong chin. Well, that's fine. I won't come forward as far. And these are personal preferences where you can alter things. Where I don't alter my personal preferences, though, is when the personal preference would amount to a dysfunction that I know is going to cause problems over the next 10 or 20 years. Like, I won't do that. And, they can go someplace else if they'd like.
Sure.
At that point, but...
Yes. Speaking about, thank you for that very detailed explanation. I'll maybe put up some visuals to help people understand better in the edit, but wonderful explanation. Speaking of jutting bony structures in the face forward as part of jaw surgery, optionally, you mentioned earlier cheekbone implants, and this is also something I think that I only ever hear come out of your office. Which is part of what made me think that you have a more three-dimensional approach to aesthetics than other surgeons who maybe are just looking at the jaws only. What's the role of cheekbone implants in your surgeries? And also, can you describe how that's done? Are these permanent implants? Or is this a bony change? Is it a soft filler? What is that all about?
That's a great question. So going back to facial development, the high percentage of people that have underdeveloped maxillas, the maxillary growth usually occurs from orbital rim, cheekbone, down through the jaw itself, not including the nose. So it's everything kind of around the nose, cheekbone, orbital rims, etc. That's considered mid-face. It's considered maxilla. And then it joins the zygoma. So there's a fusion of zygoma with maxilla, but usually the maxilla, if it doesn't grow forward, this is flat and plus or minus zygoma width. Okay, so if you're going to correct the maxilla, well, our jaw surgeries occur here and not up here. So if you correct this position and leave that, then the discrepancy becomes visually obvious. There are several ways to take care of that discrepancy. You can choose silicone. So back in the day, my partner had his own set of silicone implants that he used. Then he learned a technique from Bruce Epker, a Dallas cosmetic oral surgeon. I think he's retired now, where you mix hydroxyapatite with collagen, and you moisten it so that it's moldable. And then you mold the implants, and then you put them under a heat lamp to evaporate the moisture from them. And then the collagen binds the HA together. So you end up with a hard structure of granules that are bound together by that collagen. Just like you would do any cheek graft, you dissect up underneath here to this area through here, and then you place that graft on the bone. That graft then takes on moisture from the body, including blood. And so then it softens again. So as it softens, the periosteum or the coverings of the bone kind of gently hold it on the bone and cause it to mold without collapsing. So it maintains its integrity. Then over time, that hardens. And not only that, but the underside fuses to the bone. So there's ingrowth underneath and there's ingrowth from the periosteum. And we know this because we did the histology studies and published on it. So we have the histology studies from this, and then we have the clinical studies where me and the Verona guys and Dr. Arnett, we had about 650 implants that we followed. And the good part is that the HA is porous, and because of the interconnectedness of the collagen, it's open to vascular ingrowth. We don't get infections. The material is really resistant to infection. Second would be we do get shrinkage. So there's about a 30% shrinkage of the material. We build that in. So early on, patients' cheeks will look bigger than they ought to be, and then they kind of shrink a little bit. Lastly, the material is moldable for about 7 weeks. So if we do get asymmetries or differences when the patient comes into the office, I can actually, with finger pressure, shape it. It takes a lot of pressure. So I know on the internet they refer to this stuff as paste, but it really is not paste. It's pretty hard when it goes in, and it definitely softens. The reason I would prefer not to call it paste is because some surgeons hear that and they go in, they mix it up, but they don't evaporate, and it gets put in and it just slumps because there's no integrity to it. So I've had colleagues call me and say, well, my cheekbone graft's all over the face. It didn't stay put. And it's like, well, you got to follow the protocol. So
wow,
you can use that material. You can use silicone. Some people use MedPore. I don't like MedPore. MedPore is really hard to take out. I almost prefer silicone to that. But I love what I use because I've been using it for 21 years, and Bill was using it 10 years before that. And it really helps balance the face because that's how it grows. Your other option is to do osteotomies. So there's some brave docs who will make osteotomies and cut the bone and fracture them out and get projection and width. And then there are those that tell patients that they can do that with the, quote, high Lefort 1 osteotomy, which is dumb. So I'll just say it. The high Lefort is never high enough because there's a nerve right here. So, and you need to put your plates up here. And if you start going high enough, now you're putting plates up next to the eyeball and the lacrimal duct, and then they feel that. So as high as you're going to get is about right here with your osteotomy, but then that osteotomy needs to drop below the zygoma to get to the pterygoid plate. So truly you're not high anyway.
Yeah, why does it always need to be below the zygoma? Why can't you cut around the zygoma and move the whole zygoma forward? Because now the plate's up. Yeah, well, the plate would be up here.
You can, but then you're actually dealing with the attachment of the masseter muscles.
Oh.
And that's a huge muscle. And so as you cut through the zygoma and then back down, if you went through it and then came back down in the back, then you have this whole kind of this portion right here in the front that has a masseter tendon. And now you're bringing a jaw forward kind of with the masseter muscle. And the key to not getting relapse in jaw surgery is passive. So if you leave a lot of big muscles attached to things that are moving, it'll move back. That's one reason. The other is it's complicated. And the third is I just shove HA and Avitine up in there. So
call it a day. Yeah.
It works great, and it's been working great for us for a long time.
How frequently do you do these implants on patients? Is it with every surgery? Is it something you offer?
No,
Is it
no. It's always all aspects of the surgery are always offered. I'll tell them, hey, it's going to look a lot better if I can get some projection there to match your new jaw position. And if they insist and they're like, no, I don't want to do it, or maybe I'll consider it later, then it's like, okay, fine.
Would you say most people need it because of what you were describing, as we all have this unnatural underdevelopment, and to reverse that in the direction of nature?
A high percentage.
High percent. Interesting.
Yeah, I know back in the day, so I would say about 17 years ago, I made the mistake, or maybe not, of invading the internet space of jaw surgery. And I was like, wow, that was something. But what I learned is that, like, we were known, like, well, if you see Gunson and Arnett, you're going to get an upper multi-segment, lower jaw, chin, and cheekbones. That's what everybody gets at Arnett and Gunson. And the answer, it's not like that. Like, I do a handful of one-piece uppers in the year. That's great. I've done a handful of single jaws. If the other jaw is great, awesome. Guess what? You get one jaw. That's awesome.
Yeah.
I don't always do a chin if the chin ends up in the right place. But to your question, how often are cheekbones needed in maxillary deficiency? Well, that's a high percentage, right? Probably 75% of those patients need it.
What about nose jobs, rhinoplasties along with jaw surgery? Do you ever do that?
Personally, no, because I just wasn't trained to do it. My colleague, Dr. Raffaini, does them at the same time. So he'll do nose jobs with his jaw surgeries. He's really amazing at it. Personally, I feel like the nasal structures change dramatically in relationship to the jaw position and the lip position. And I often counsel patients to wait to do their nasal surgeries after jaw surgery. Mostly because, in my experience, a lot of them decide to not need it. Like, they're like, oh, my nose is fine now, I don't need it. And then I will often recommend, because I never know in a consultation whether or not somebody's going to have surgery with me or not, but I want them to have all the information. So I tell them, you're better off fixing nasal deviations post-surgery, because the jaw surgery itself can result in poor healing of the nasal septum, and you can end up with a nasal deviation, which I've seen in a lot of revision consults. So then also, if your nasal septal deviation is low, let's say at the level of the inferior turbinate or below, that's manageable. Like, I can manage that and go up there with an instrument and remove the tissue needed to straighten it out and call it a day. So if your nasal septal deviation is low cartilage in that area, great. If it's high, if it's up in the dorsum of the nose and the bones up here are high and posterior, that's outside of where I work.
Yeah.
But I don't bemoan other surgeons from doing that. That's fine, as long as. Again, you just careful with your diagnosis. I've seen people over-reduce noses and over-advance jaws and end up with these little tiny things on the face, and that's not great.
Besides cheeks and nose, what other peripheral surgeries or additions to surgery can be done to zhuzh up facial aesthetics that maybe Dr. Raffaini is doing? I heard something about bone shaving and fat grafting. What's that all about? What does that even mean?
So, we can do that as well. So here's, so let's start with ancillary procedures. In a lot of patients who grow long and you shorten their faces, the tissues go this way. So you can shorten a face sufficiently as to create a basketball head. And in which case, if you're not managing the cheeks or the buccal fat, then you end up with people who are just too round.
Wow.
Now here's where you need to be really careful. So in judging, is it buccal fat or cheekbones, you have to make the diagnosis. If it's buccal fat, you can remove some of the buccal fat and regain some of the concavity in this area underneath the cheeks. So a lot of times with facial shortening, you do a little bit of buccal lipectomies. Other procedures, submental lipectomies, we can do those. So people who want more definition underneath here, make a little incision, suck the fat out, let it redrape, and it looks really nice. Patients who have condylar resorption, they're high angle, but their ramus is short relative to the front of the jaw. So you establish the front of the jaw, and without addressing the angle, again, they look like two different people. Like this is short and not visible, and then this becomes strong from the counterclockwise rotation. So the same material I use in the cheekbones, I can create angle grafts back here.
Wow.
To match the lower jaw. So those are just some ancillary procedures that are part of the treatment planning. Other surgeons will, instead of using hard tissues in these areas, like Dr. Raffini, he uses fat. So he'll suck fat out and do fat injections along the jawline to increase the dimensions back here and up through here. He'll do nasolabial fat, which I've done, lip injections, which I do as well. I prefer addressing the hard tissue with hard tissue solutions. If there's a hard tissue problem, again, treat the problem where it lives. Mirko is, he's a sculptor. He can sculpt a face, and plus he has the added advantage of working with all those Italian women that just, the quality is outstanding. So
Right.
His results are always like getting applause in meetings and things. So
good starting materials.
Yeah, exactly. Good base material. But so you can choose to do the fat grafting, which is a more permanent solution than, say, doing like Restylane or Voluma or other things, which those things also have their side effects.
Yeah. Is it a coincidence that Dr. Raffaini is Italian, just like some of the great sculptors were? Is that random? Or is it like,
no, because there's plenty of, there's plenty of Italian surgeons that stink at what they do. So, it's not, I think it's just Mirko. So early on in his career, he went kind of around the globe to learn, about jaw surgery and nasal surgery and fat transfer and lifts. So he learned nasal surgery from the best nasal surgeon, and I think he's in Chicago. He came to Santa Barbara. He learned how to do jaw surgery from Dr. Arnett. So he takes all of this, and I think those are the best surgeons who are able and open to taking information from all places and combining it into what he does. He's also very good at what he does because he has long been partnered with Dr. Cocconi, who's a masterful orthodontist. And so that helps Mirko with his results as well. This getting great dental solutions. It's by no means like Italian, but he is very Italian, meaning, he takes very serious, when we go over for dinner, it's, dinner is a very serious affair. It's good, it's yummy, and, and he likes his cars and how they're made. And so it's in him as a person, I think, is this demand for aesthetic experience. And that's what makes him good. So you can have that same person, in Romania, that's fine. Right. But that's what makes him good. And, it's what makes Simona's good and Andre good as well. These guys, they're really intent on achieving the natural result. And I think that's important to recognize too with jaw surgery, is that it's a restorative solution. We're restoring what should have been. If you want to look like somebody else, you're better off, going to the plastic surgeon to have your facial structure revamped. I don't see me if you want to look like, I'll take what you have and I'll give you what you should have had, but I'm not going to turn you into like
Angelina Jolie.
Yeah, and even she did it, right? Yeah. So she had procedures done to look the way that she does now. And That's fine. If that's what you want, then you go get that. But I'm more of a restorative surgeon. I do have a relationship, for example, with a surgeon who's does facial feminization, right? So in the trans population, that they want facial feminization. I have an influence, like orthognathic wise, I can make a more feminine face how I manage the advancements and the sagittal rotations, and I can make a more tapered face. But in the end, the substructure is very masculine because of the testosterone that existed during development. So there's greater muscle size, which means that there's greater bone volume because of the pull of the muscles. So there's all these different things. So in the relationship that I have, like if there's a basilar bone problem, then he refers to me to establish that basilar bone problem. And now I put my cosmetic solutions on the back burner. So I'm not doing cheek grafts. I am not doing genioplasty. I'm putting the teeth together and the bones in the right place. He then will take his plastic cosmetic craniofacial training and sculpt the face to be something that is different.
Wow.
And that's his prerogative, and that's what he is good at. Again, am I good at that? I can do it to an extent. Like I can shave bone here and there if it's inappropriate. But in general, I'm just putting the basilar structures where they belong.
Yeah, that's very.
I don't mean to minimize what I do, but really, I'm not a jack of all trades in that regard by any means.
Well, it's interesting that you describe a surgery that a lot of people freak out at and consider it to be very invasive and unnatural. You're basically describing it as exactly the opposite. It's the procedure that gives you the face that nature had intended for you to have, and really nothing more, nothing less.
Yeah, sometimes we have a little saying, sometimes the most conservative solution is not the least invasive.
Yeah.
Right? Because a lot of times when we talk conservative, we're just talking about a moment in time. But when you add time to our existence, then sometimes the quote conservative intervention is not, because things break down over time. It's almost like so we didn't talk about like minimally invasive surgery, which is a great effort. Like I try to be as minimally invasive as possible, but I'm not going to be so minimally invasive as to compromise me mobilizing the upper jaw to prevent relapse, or impeding my fixation, which would again lead to relapse.
What is minimally invasive surgery? What does that mean? For the people who use that term?
Yeah, it just means smaller incisions and smaller dissection. So they generate instruments and techniques that minimize the size of the incision and the amount of dissection, which is great.
Specifically with respect to orthognathic surgery?
Yeah. Mm-hmm.
By the way, this seems a super silly question. Silent G or non-silent G? Orthognathic. Orthognathic.
It's a nya sound.
Okay, so it's like Gnostic.
Yeah,
okay.
Exactly.
Okay, thank you.
Orthognathic.
Okay.
And it's maxillofacial. It's not maxio. So, those that wonder.
Not even in Barcelona?
Well, I don't know. Things are very exciting in Barcelona. You'd have to ask Federico.
But continue about minimally invasive surgery, because that's also something Dr. Alfie brought up to me.
Yeah, there are two large proponents in the world for minimally invasive. One is Gwen Swennen, really great guy in Belgium, and he has designed a whole surgical system for minimizing incisions, both in the upper jaw and the lower jaw. So he has kind of a new instrument tray and plating system. It's all meant to go together, and he travels around teaching that. So he's one kind of proponent. The other guy that makes a lot of hay out of minimally invasive is Federico Alfaro Hernandez. So he says minimally invasive, and he does. He makes small incisions and uses larger plates in the anterior maxilla with less plating in the back, because that way he doesn't have to dissect so much in the back. So there are alterations in technique to minimize dissection and incision size, which is great. I mean, it's great if you can get the result. If one of my colleagues calls minimally invasive surgery minimally effective, but that's his opinion, and it just depends on the surgeon performing the job. So that's something that's new and I guess exciting in orthodontic circles.
Yeah, but maybe the compromise and result is not worth an easier couple of weeks of recovery after surgery. Is that the idea? We're trying to lower the stakes.
Yeah, and again, to go back to your stated goal, do you want to pick a surgeon because they do minimally invasive surgery? The answer is only if it makes them better at the final result. Yeah. You don't ever want to do any one thing simply because it sounds good. If it's going to completely alter the way that you do other things. Yeah. It's kind of like orthodontics too. Like I would never dictate to an orthodontist what brackets to use, how to use them, whether to use aligners or brackets. Like there are guys I know that fail at brackets, but they're wizards at aligners. Like they can put the teeth wherever you want them if you ask them to do it with aligners, but ask them to do it with a bracket and they fall to pieces.
Right.
And same other way around. So like I would never tell somebody what to do. And as a patient, I would give your viewers the advice, don't ask your surgeon to do things that they're not comfortable doing because you heard that it's better. The surgeon will actually tell you what they're comfortable with, and then you accept it as given. But asking them to try something that's not good. You're asking for a bad result.
Yeah. That's frequently advice that I myself give to other patients too. So
cool.
Yeah, we're on the same page about that. Doctor, I'll let you go. I know I kept you longer than promised.
No, Ron, it's fine.
Thank you so much for your time, for your willingness to share and say a few controversial things. We appreciate that. And keep on making beautiful, healthy patients. We really appreciate the work that you're doing, Dr. Gunson.
Ron, thank you, and bless you for your journey, and that you're willing to share your journey with other people. Good job.
Thank you so much, Doctor. Bye-bye. Have a great day.
Take care.